Dr. Devashish has not joined in.
I'll call him, ma'am.
Yeah.
Ma'am, we are live. I'm starting the video.
Good morning, good afternoon, one and all of you. Why is it? What is happening?
Ma'am, we are live.
Have you played the video?
Ma'am, you can start.
Huh?
Yeah, video has been played, Chitra.
Okay, okay. A very good evening to one and all of you. We look forward to yet another very vibrant webinar of ARC, that is Challenging Debate Series today. We have with us great leaders on the expert panel who will be steering the webinar to get the maximum benefit for all the attendees watching. We have with us on our expert panel our Honorary General Secretary, Dr. Namrata Sharma, our past President, Dr. Ramurthy, a very popular ophthalmologist from Chennai, Dr. Mohan Rajan, our past President, Dr. Debashish Bhattacharya, and one of our popular teachers, Dr. Kamaljeet Singh from Allahabad, to adorn this section. I have Dr. Srinivas Rao with me to moderate this interesting session. Our first team to start the challenge are Dr. Srish Kumar, Senior Cataract, Cornea and Refractive Surgeon from the Eye Foundation, Coimbatore, who is going to talk on why I prefer CTR early in all cases. His opponent is going to be Dr. Atik Sheikh, a very young, energetic surgeon from Chennai. On to you, Dr. Srish. Can you screen share? Dr. Amit, you should stop sharing your screen.
Oh, sorry.
Thank you, Dr. Chitra, and the ASC team for the opportunity. And so the timing of insertion of CTR is debated. It was once famously said, as early as necessary and as late as possible, which remains a matter of opinion and experience. I believe in early insertion of CTR. There are various publications which have confirmed early intervention is much better as compared to late intervention. And this is a study which was published in Current Opinion in Ophthalmology. And the convention has been to place the CTR at the earliest concern of cellular weakness and prior to lens extraction. This provides advantage of capsular support intraoptically. Additionally, early placement is commonly believed to allow capsular distension, which may prevent damage to the bag during most crucial steps of the surgery. And another study, again, it was published in JCRS. It showed reduced zonular separation and increased capsular IOL fixation in cases with pseudo-exfoliation syndrome when a CTR was implanted before phaco emulsification as compared with the control group for whom no CTRs were implanted. So I just want to show a few case examples. This is a case of severe PXF with severe zonular dialysis. In such cases, it's very difficult even to do a rexis because the cataract is shaky, and the CTS should be implanted at any step after capsular rexis and hydro and visco-dissection. An intact capsular rexis is necessary for implantation. That can be stabilized during the procedure with the capsular hooks. You can see the kind of wrinkling of this capsule. Another case, this actually is a well-dilated cataract, well-dilated pupil, but on injection of saline itself, you can see there is a zonular dialysis in one particular quadrant, and vitreous started coming out. And this is a case which needs a local anterior vitrectomy, and as soon as the capsulorhexis is done and hydro is done, CTR has to be implanted. Another case is a total cataract. There was no phacodonesis. This particular patient didn't give any history of trauma as well. So probably it is a traumatic cataract only, but realized it on injecting air bubble into the antechamber. The vitreous started coming out here, and then I injected trypan blue. You can see the vitreous blob coming out. This again shows there is a dehiscence, zonular dehiscence, and so with the local anterior vitrectomy, we should go ahead and do a limited vitrectomy here, either with the help of a capsular hook. We should stabilize the bag and then proceed with the capsulorhexis and phacoemulsification. But my friend went ahead with the phacoemulsification. He wanted to inject the CTR later during the course of the procedure. So thinking that placing CTR will disturb his phacosurgical procedure, but soon he realized the bag was not stable during the process of phacoemulsification. The zonular dialysis increased, but instead of doing the extracapsular, ended up with intracapsular cataract surgery. Another case is a very small pupil. It's a undilating pupil. It's a non-dilating pupil. It's a Marfan's case with severe subluxation, and after the capsular hooks placed to increase the size of the pupil, so he went ahead with the phacoemulsification. He wanted to do a heroic surgery without placing a CTR. He succeeded in doing a phacoemulsification and wanted to place a CTR in the end after phacoemulsification. You can see the kind of distortion you see here. There's such a large zonular dialysis here. This should have been avoided had he placed a CTR early in the stage of the surgery, immediately after hydrodissection. Should have placed the surgery. Somehow he ended up with a lens implantation. Not sure where the lens went, whether it was inside the bag or in the sulcus. And the next day, but next day it was in the vitreous cavity. So the vitreoretinal surgeon had to help him in bringing the lens to the antechamber. So this is another large case. My friend wanted to place a CTR after phacoemulsification and found the bag was not stable, and placed a CTR, didn't go the right area, and developed a large zonular dialysis, did not place a lens. And this is a third week postoperative video, and you can see the CTR and crumpled bag. You need to remove both. And after anterior vitrectomy, iris clip lens was placed. This again could have been avoided had he followed standard protocol of placing CTR early in the stage of the surgery. So, true prevention is not waiting for bad things to happen. It is preventing things from happening in the first place. And early intervention definitely gives favorable outcome, and that's why I prefer to place a CTR early in all the cases. Thank you very much.
Thanks, Rish. That was a good talk. Dr. Atik, you really need to get energetic because you've been plastered by Dr. Shrish here.
Can I start, ma'am?
Yes.
Sure.
So why I prefer to place CTR late? So I'm here to present two videos. This was a case where you can see about 2 to 3 clock hours of zonules not being present. and coloboma also, lens as well as iris coloboma. Rhexis in these cases is a little difficult, but doing it slowly, we can get over it. Doing a gentle, very slow hydrodissection and a delineation just for me to know where the nucleus edge is. And Phaco in these cases, we have to be very cautious, be gentle, do whatever technique you feel is comfortable and you're happy with. And the parameters, these cases, you need to be slow. If we have high aspiration flow rate and vacuum, that itself can cause breakage of the anterior hyaloid. And removing the probe is something that is very crucial. We should not pull out the probe, inject visco and then pull it out. Cortex, we should ensure that we pull tangentially and not straight. That will ensure that the dialysis gets bigger. So in such scenarios, we'll be able to get away with it very comfortably. You can see here, everything is clearly visible. When the nucleus is present, we cannot be very sure where the CTR is going. You can see the capsular rim is clearly seen and cortex aspiration was actually a breeze. When the CTR is in, cortex aspiration really becomes very difficult. And you can see that the lens is again put into the capsular bag and the lens itself adds to support. So gently nudge the lens into the capsular bag. And this is case number 2, a mature cataract with about 2 to 3 clock hours of zonules missing. So that is clearly visible. Because this was a white cataract, we're trying to stain the anterior capsule for better visibility. And Rhexis in this case was a real challenge. The nucleus itself was hypermature. And of course, with the dialysis, it is not that easy. But with re-injecting, you can actually do quite a good Rhexis. I don't have access to femtosecond cataract here. So this is what I could do. And Phaco, making a gentle nudge, creating a groove. And I'm here going ahead with the chop and splitting very gently. It is not advisable to split completely. Split, go down and split further. That will ensure that we don't traumatize the zonules still further. And now the second crack is made. As I said earlier, Phaco parameters in these cases very important. You cannot play with usual high aspiration flow rate and vacuum. It has to be gentle. No harm in spending those extra few seconds in such cases for the benefit of the patient and to get good post-operative recovery. In this case, again, the space between the cortex and the nucleus is very less. So getting a CTR in early is actually difficult. Keep the probe in and then inject visco, ensure that the chamber doesn't collapse and gently tease the cortex out. Again, for IA, we have to use slow aspiration flow rate and vacuum, reduce the bottle height and spend those extra few seconds so that we'll be able to do the case comfortably. IOL placement again is of paramount importance. You can see here, CTR implantation is very simple. The capsular margin is seen very clearly. You can be totally confident that the CTR is going exactly where you want. I'm more comfortable pushing it in this way. However, if we are more comfortable using the injector, we can do it that way. And the eyelets have to be positioned in such a way that we have adequate support. And the haptics are moved into position in such a way that the bag stabilizes better. Even better scenario could have been a 3-piece lens would have been even a better support. But then we went ahead and did a single piece IOL implantation. So this was the end of surgery of both the cases. Well, Sirisha showed us studies which support CTR.
1 minute left.
We are showing cases where CTR placement late can be comfortable. Aiki Ahmed did a great trial where he says that placing CTR with the nucleus can cause more trauma to the bag and to the zonules, and it can cause damage to the zonules further. And the cortex can get trapped with the eyelid, which will make IA very difficult. In hard cases, as I said earlier, there is no space, so getting the CTR in is actually very difficult. And in soft cases, the epinucleus or the cortex can get trapped, and getting the cortex out becomes a real challenge. Main advantage of placing CTR late is we can visualize well and ensure that the CTR goes exactly where we want to do. Cortex aspiration becomes much more simpler. So CCC can be visualized much better and CTR can be placed easily. So I'm also telling the same concept, the same thing. Place CTR as soon as you need it, but as late as you want. Thank you, Chitra Madam, Team AIOS, and my mentor, Arul Sir. Thank you. Thank you very much.
That was good, Adi. So I have one question to the expert panel. Early CTR implantation, as Shrish was saying, can have a tendency to increase the capsular torque or the displacement of the entire capsular bag. So how could it be avoided?
Want me to answer or?
Yes, yes.
No, I like both the presentations. I would like to congratulate both Sirish and Atik for that. But I would like to say that I would put the CTR as late as possible for simple 3 or 4 reasons. One is because early, when you put it early, you do not know where it's going. Number one, it's a little blind technique, especially when the cataract is dense. And very difficult to, maneuver the CTR through the nucleus, dense nucleus, number one. Number two, always cortex removal is going to be difficult. Then you do not know exactly how much of zonular dialysis is there. So whether to put a CTR or CONE, you do not know exactly. That we decide at the end of the surgery. And if you have a PCR or a Rexis tear, and then if you CTR, retrieving the CTR of the sulcus is going to be a huge problem. And especially when CTR goes into the vitreous cavity is even more problematic.
But
so, yeah.
Having said that, I think a capsular hook should have been placed.
Yes, absolutely. That is what I wanted. I think I fully agree with Atik. Only thing is, he has been very lucky. I would have put a capsular hook for all these patients because this radial stability is much more important than the circumferential stability at this point of time.
Yes.
Yeah.
I think.
Yes.
So just a quick point. I mean, I would tend to agree with Shrish in the sense that, the 2 cases that Atik showed were fairly stable bags and he could get away with it. But in case, once you stain the capsule, there is the making out the Rexis margin is not a difficulty. Once you do some amount of visco dissection, you can always create a passage. Yes. In these cases, I would always like to pass a suture through the eyelid, just in case, like Mohan mentioned, if you get into a mess, then you can easily withdraw the endocapsular ring outside. But the only serious problem that we have when we place the endocapsular ring early is getting the cortex out. But in all cases, by tangentially pulling it out, we are able to take it out. There hardly been a situation where I have not been able to take out cortex. So whenever it becomes necessary, the same old adage, I think is going ahead and placing it is a good idea.
Yeah. So it makes sense to inject viscoelastic, a good hydro, and also use a second instrument to guide the CTR in. And as Dr. Ramurthy said, have a eyelet threaded, which will be a further guide. What can happen, Dr. Shrish, I wanted to ask you, if you have placed a CTR already and the surgery is going on, you have a PCR, how would you deal with it? The CTR is in the bag.
Sirish, it's a small PCR. It's not a very big PCR.
It's a small PCR.
No, it's like if it is a small PCR, we need not do anything. Like we just do a anterior vitrectomy and go ahead with the surgery. And like if it is a large PCR, and if you're doubting the integrity of the capsular bag itself, and the capsular CTR, the capsular tension ring might escape into the vitreous cavity. In such cases, it is a difficult proposition. We have to deal with it with the help of a vitreoretinal surgeon. So small PCRs, definitely you can go ahead with the regular procedure.
But I think there would be a situation when you would decide to place a CTR early. Can you, would you have had a severe pseudo exfoliation?
Yes, madam. If we are not, there is times where you start with the Rexis and we are not able to get control at all. As Ramurthy sir rightly said, I'm also telling the same. If the dialysis is big and if we are not able to get the capsule around 360 degrees, then we'll want to place it early. Or in these cases, doing a femtosecond assisted capsular Rexis will really be beneficial. So capsular Rexis is actually a big challenge. So cases where we cannot do it initially, we'll have to do, madam.
So the take-home message is that we would judge the situation, but definitely if you're not placing CTR early, a capsular hook is absolutely mandatory, and we should ensure that there's a good hydro dissection and a visco dissection is also done, and that's most important. Doctor, yes?
The combination of both, I think, should have both CTR and both circumferential and radial stability of the bag as well. So you need capsular hooks as well as the CTR. CTR, you can put it late, and capsular hooks, you can put it early.
Yes. Dr. Srinivas,
Yes, madam.
you have any question, or you can introduce the next team?
Good evening, good afternoon, everyone. Welcome to the mega debate field. So our next team is going to be Dr. Swapna Nair from Chaitanya Group of Hospitals. She is the medical director and a leading cataract, cornea and refractive surgeon. And I must congratulate the whole Chaitanya Group for completing their Silver Jubilee 25 years of successful service in the eye care. Congratulations, madam. And she would be speaking on, I would prefer to use Barrett's formula in all my IOL power calculations. And her opponent is Dr. Amit Gupta, a senior cataract, cornea and refractive surgeons from the prestigious Postgraduate Institute of Ophthalmology, Chandigarh, to talk against the motion. Over to Dr. Swapna, please.
So let me just share my screen. Is my screen visible now?
Yes, yes, yes.
Good afternoon, ladies and gentlemen. Thank you, Chitra ma'am, for having me here. And yes, I would like to use Barrett for all my IOL power calculations. Now, why? Because Barrett is not a single formula. It is a repertoire formulae. So you have the Barrett Universal 2 along with the toric and the total keratometry Universal 2 and total keratometry toric, which form the Barrett suite along with Barrett True K and the Barrett treatment formula, True K for refractive, post-refractive cases, and treatment formula to align toric IOLs that may be giving you residual pass. So now here you have a whole range of treatment conditions that you can treat, conditions that you can deal with using the Barrett formula. Now, this slide is basically to highlight that this formula need not only be used with optical biometry, but is compatible with contact ultrasound A-scan as well. Now, I'll come to that a bit more later. So this is it's a part of a master chart that we did a study for using Barrett Universal 2 for both optical as well as ultrasound axial lengths. So one is the lens star on one side, immersion on the other, and you can see that even when you incorporate the axial length and the other values like the lens thickness or the ACDs obtained from the immersion into the Barrett Universal 2, you get very similar values in both cases, both optical and ultrasound. So that proves that it is a formula. It's a truly universal formula. Now, coming to special situation, here I'd like to highlight a couple of cases where the usefulness and the versatility of this formula is proved. So coming to premium IOLs, now this is a patient who required a panoptics, and you can see that across all machines, the lens star on the left and the anterior on the right, you get similar values, though the patient is a myope. Now, in toric calculations, Barrett toric calculator has been incorporated into the calculators of nearly all the major companies that provide toric IOLs, which itself is a testimony to the fact that it is a good formula incorporating the posterior corneal astigmatism as well into calculations. You get the sphericity, the toricity, as well as the intraocular lens alignment that is required using this calculator. Now, this is a silicone oil-filled eye, and an immersion scan has been done. And you can see that the IOL power that we gather is 25 diopters over here, whereas now the same eye underwent a Barrett calculation. You can see that the power is 22.5. So this variability, the consistency with the Barrett, 22.5 was the right value. Now, why it happens to be so is that when you use the optical scan and the corresponding formula, you're avoiding the fluid oil interface, and because the patient is sitting, that error induced by the probe is avoided. Now, post-refractive surgery cases are very dicey to deal with, especially they are much on the rise right now. So you can see on the right side, you have an ultrasound, which gives you something to the tune of 8 diopters as intraocular lens power, all the way to 10.5 on optical. But the ACRS calculator, which is pretty accurate in a lot of cases, you can see gives you a power very near plus 13 diopters. And if you look to the left below the chart, you have the Barrett True K formula there, which also gives you exactly the same power. So the AIOS gives you an average of all these formulae, whereas the Barrett in itself has calculated the same power
1 minute
for
left.
the patient. Now, with respect to axial length, if you look at this chart, which has been shown very often, you can see that Barrett 2 is the only one which does not require modification across all axial lengths. There has been some skepticism regarding hypermetropia, but if you see this chart, you'll see that Hoffer Q, which gives the correct value of 25 diopters with the ultrasound, is corroborated by Barrett's on the right with the same IOL power. And dense cataracts, of course, the composite algorithms of all optical instruments can calculate power, so it can be used even in dense cataracts. So this is basically to show that it is a truly universal formula. It has multiple factors factored in, and therefore gives very consistent and persistently optimal results. Thank you very much. And thank you, Dr. Srinivas, for that nice introduction.
Thank you, madam, for that lucid presentation. Thank you very much. You gave most of the points in just 5 minutes. I would like to call upon Dr. Amit, please, to fight it against and say that, no, I have my different cases and different IOL powers. Go ahead, Amit, sir, please. You need to unmute yourself, please.
Amit, are you there?
Yeah, he's there. Needs to unmute.
Yes, just give me a second, please. Well, thank you very much, Dr. Chitra and the AIOS for inviting me for this very interesting debate. And I would like to congratulate Dr. Sapna. She has really talked very nicely about Barrett's 2K. And however, there's more to biometry. So I'll be speaking
you
on
have
why.
to share your screen.
Share your screen, sir. Amit.
Wait.
Amit, I think you're on your phone. Yeah.
Yeah.
Did you get that?
Yeah.
Yeah. Yes. Go ahead.
Yes.
Hmm.
So I would like to say there's much more to biometry than what has been talked to you. So why I like to customize my biometry, and I would like to overlap with why I like to optimize my biometry. So if you look at customization, that's to build or modify a particular specification or preference. And optimization means generally getting the best out of anything. So although we are, at better with Barrett's, I'm sure there's room for best. So never let it rest till your good is better and your better is best. So what we have achieved till now is we have great incisions, laser incisions and small incisions, good CCCs, unparalleled accuracy and axial length measurements, sophisticated measurements of corneal shape and power, and much improved quality of the IOLs, which reduce the errors. But we need to move out. We need to move out and understand optimization. And for that, we need to understand why. We need to understand that we need to move out of this generation, the fourth or third generation formulas into the classification which is based on method and data. So if we reclassify IOL calculation formulas, we look at regression based formulas. So they analyze their previous data and they do not rely on optics. So these are SRK and SRK2. And if we move on to Vergence formulas, and Barrett's universal formula is one of the Vergence formulas. So currently, this is what we are mainly using nowadays, and this takes into account all the refractive surfaces of the eye. And so they become more accurate as we add on more variables. If you look at this, you will see that already we have the Holiday 2, which uses 7 variables, and the Barrett's Universal 2 uses 5 variables in this. So this increases the accuracy of these various formulae. The problem with Vergence formulas are that they are predictive formulas. So what do we mean by predictive? So they predict the position or the effective lens position of the eye. So that's not going to be entirely accurate. And also it relies on the Gaussian optics. So what is Gaussian optics? It means that it assumes all light rays to be parallel. And that is not true. We know the paraxial rays are not parallel. So there's a mix of exact calculation, plus there's a bit of fudging, which goes into this. So how can we add another dimension to the IOL power calculation? Or is it possible for us to add another dimension to the IOL power calculations? And would the results be improved if we use physiological optics rather than the physical optics which all these formulas are using to improve the outcomes? So we know the eye is a biological tissue. It has small dimensions and it requires clinical measurements combined with physical optics to meet the clinical entity. So we have eyes, long eyes, short eyes, post-refractive surgeries, ectatic eyes. So many of these situations arise. So how can we customize and optimize the power calculation? All these formulas, they are using different algorithms. We have the Bangkok algorithm, we have the Abulafia-Koch algorithm for toric IOLs. And also we have other formulas like Ladder's super formula. So what it does is, it's a kind of customization because it combines the best of various formulas to give us the best results of biometry. It means that no one formula is actually the best panacea for our patients. We can incorporate artificial intelligence with theoretical optics, which is in the Kane formula. And what else? We have the artificial intelligence or machine learning. So if you see, it's like a small tree growing. So with the Barrett's, we are somewhere, in the middle stage. We have watched this tree grow, but with the artificial intelligence, we know what is the future. This is going to keep growing. It's a growing science. And as time goes by, we will find that it will be much, much more accurate even than it is now. Already it is better than other formula. And add on the ray tracing. So what is ray tracing? Essentially, this diagram I took from physics, some kind of a publication. So it shows that there's the inputs, various variables inputs are analyzed with radial basis and gives the output. So it's far more sophisticated and accurate. So if you look at the benefits of the Hill RBF, for example, it's purely data driven. It's free of limitation of estimating the effective lens position. And the Hill RBF method demonstrates its performance to be equivalent or better than the latest generation formulae, including Olsen and Barrett's. There's no need to calculate the surgically induced astigmatism, and only the IOL calculation approach that provides the surgeon with information with reliability. So what it does is it gives us inbound, outbound. So inbounds is that the software is analyzing the result and saying that, listen, this is okay. It's okay to rely on this data. And if it doesn't have in the database, it will tell you that, listen, this is out of bounds. And you need to be careful with that. So which other formula does this? It does have some problems that it is based on empirical data. And this data is fed in, its accuracy is limited by the type of... All right, so I would just like to conclude that although we have hit a temporary ceiling for IOL calculation accuracy, for normalized at approximately 90% of the eyes within plus minus 0.5 diopters of target, and of course lower for more complex eyes, the future is even brighter with formulae and customizations, which we need. We cannot rely on a single formula, even though it's a very good formula like the Barrett's universal. So perhaps IOLs in increments of 0.25 diopters and modification of post-operative power will also pave the way forward for us. Thank you very much.
That was very good, Dr. Amit. Of course, Swapna gave a great talk on telling us why Barrett was the only way to go. But I thought you might get a little challenged, but you dealt with it very well. Swapna, just in case, if you would you believe in just holding on to Barrett, or would you like to have a try at times to compare with the other IOLs, know whether you're on the right track, especially when you're dealing with a very small eye or a very large eye?
Yeah, there was a time when, we used to think that SRK2 and SRK-T are pretty, much the way to go. And as we started using Barrett Universal 2, we found out that we could get much, much more accurate values using that. So now we have completely shifted over and we rarely go back and see. But regarding the artificial intelligence formulae, they always have bounds, beyond which you cannot go, like, dioptric bounds, like 50 diopters or so. So beyond that, the machine is still learning on how to, gather data and give effective IOL power calculations. So I'll be a bit cautious using that for, extreme values of axial lengths and keratometry values.
Any thoughts from the expert panel?
I think Swapna put it very rightly. Of course, the Barrett formula is there and it does bail you out in most of the situations. But there are times when the cases get tricky, like post-Phaco or post-LASIK, or when you actually need to consult 2 or 3 formulae and then finally get to the point where you choose one of them. Sometimes you choose the middle path and sometimes you take the average. So, or maybe
everybody on the mute.
there is an echo, I think.
Echo, yeah.
So for most cases, Barrett would probably bail you out, but for some of the outliers, this side or that side, you may need help of other formulae also.
Madam, can I give a comment here? Is that, we have various versions of formulae like the Hill RBF coming in, and we now are moving on to the version 3.0. And because of the larger database, what is positive about it is that it's growing and it's going to grow further. And unlike formulas which remain static, once they're good formulas, but this is going to grow further. So in another 5 years from now, maybe we'll find it that it's the number 1 formula.
Most practitioners would like to have a go-to formula. So they don't have the time or the inclination to play around with too many things. And Barrett, because of its multiple ease of availability, not only in the IOL kind of instruments, but also on the websites, is something which takes care of most of our needs. Like somebody said, Lada's formula, you can even put the patient's shoe size into place. Whether it's relevant or not is questionable. So we need people like you, Amit, to push the borders. But for most, practitioners, I think Barrett comes as a boom, where there's easy accessibility, and majority of the cases it works for them.
Some echo is there, ma'am.
I had a question to you.
Yes.
There's a recent paper from RP Center comparing the 4 formulas, that is SRK2, T, and the Barrett's Universal which is the most accurate for predicting the post-op refraction in the wide range of axial length. I think it's been published in IGO just this year, in 2020.
Yeah.
And it's been shown that the Barrett's formula scores more is because it has wide range of axial length calculation. But if we look into what Dr. Amit said very nicely, that the Gaussian optics might have certain disadvantage. So do you think that comparison with the one with the Gaussian optics and one take an AI-based formula like Lada's formula or Hill RBF formula, take two comparison, take the best average and whichever suits the best, or directly go ahead just with the Barrett's formula?
No,
as of today, I will go with the Barrett formula. In my opinion, there is no debate as of today because Barrett formula is universal. That is why it's called universal formula across all the thing. The only area where I find Barrett formula a little problematic is less than 20-21 millimeters of axial length. When you go for hyperopia, there is no formula which is very good, and Barrett is also not very good in that. At least in my practice, in my experience. I want to know from the panel, other panel.
Yes, Namrata madam, go ahead.
No, I think that study looked at comparing 4 different formulae, but then if you would see that there were not, most of the cases were in the normal group. There are not too many outliers this side or that side. So it said that Barrett is the best, but like Dr. Mohan Rajan is saying, for hyperopes, maybe it's not there. And like Amit says that it has to be more dynamic. So I think as far as formulae are concerned, we don't have a one size fits all kind of a thing, or any one single formula which fits at all places. It is an evolving thing, and it will keep evolving and get better with time.
Quick question to Ramurthy sir. Sir, in cases where you do the IOL calculations, do you take all these 3? Because few of the surgeons, they prefer taking 3-4 formulas like Holiday formula, Barrett's or Hill RBF. Try to get a comparison amongst the 3 and then go for the average, or you just want to go ahead only with the Barrett's formula?
No, I think, it often becomes a problem when we have 3 or 4 different formula giving different values. Which one is accurate? And you're not averaging out mistakes here. So obviously you have to put your trust in one particular formula. Similarly, sometimes you have different instruments giving different readings. And in that case, we use what's called a Barrett RX formula to find out the median of the different readings that are coming in. Last 3 or 4 years, whether we are using a optical biometer or a immersion A scan, for all kind of situations, we are stuck on to Barrett. And it's not just the published literature. In our own experience also, where torics or post-refractive or these things, results have been quite tight. Of course, outliers will always be there, and there's always scope for improvement. But for a busy practice, I think if you need one particular indication, maybe this is the way to go.
Dr. Amit, that was a very good answer for all of us. Dr. Amit, just supposing a person is using the AICRS calculator and not the Barrett's calculator, and there are 2-3 values which come in. Can you give just one short brief, like what would you use if it were a myope and a hyperope, if there are 3 options of IOL part given in AICRS calculator?
Yeah. I mean, which power would I choose in a myopic patient?
Yes.
I mean, the best thing is we have the intraoperative, biometry, and that would be the best. And it's advised that when in doubt, that you should preferably use the aura, and we found it to have great results. And besides that, what happens is that some people use with Van Cock's adjustment. That is something which gives us more accurate reading. I would still leave the patient on the myopic side. I think that was the question which you were asking.
Yes, yes.
Just one more comment I would like to make is regarding the popularity of Barrett's true case, that because very few people have access to the lens star. And I think Hill RBF is not that difficult to do. It's simply that the Barrett's Universal is so freely available, so much more than online calculators is a bit tedious, and so many of us don't do it. So maybe with in future it becomes more popular.
And regarding the ASCRS calculator, did you mean only for post-refractive cases or any case in general?
Post-refractive.
Definitely, because it's an average of multiple formulae, and it corresponds a lot to the true K value also. So that is pretty much accurate compared to just one single reading from a Universal 2 or a Holiday or whatever.
I also regarding your question on post-refractive multiple formulae giving different values, if it's a post-myopic eye, most often you get a hyperopic surprise. Yeah. So I would say you go for the highest power that's given. If I get 20, 21, 22, I'll go for 22. If it's post-hyperopic classic, then you get a myopic surprise most often, in which case I would go for the smallest number that's shown up by the ACRS calculator.
So that means, do you mean to say that you will take the minimum? It has a minimum, a maximum, and an average. So is it that you will take the minimum over there?
Now I would go with the Barrett 2K formula. But when I was using the ACRS calculator, this was the dictum I used to follow. And as most of us, it was more often myopic classic than hyperopic classic we used to face. In those cases, always plumb for the highest number. That is, if it's 21, 22, 23, go for 23.
No, even for -1, always the Barrett true kicker formula, if you say, it will give that it's -1, what is the power? Exactly. So always aim for -1 for these patients.
I think
in 22, go for 23.
In post-fracture surgery cases also, I think I agree with Amit completely. Aura really helps you a lot. Sometimes whenever there's a confusion, and you can always cross-check with the aura. So if that is available, then that's...
And the second thing that we really want to focus on is the equivalent K reading. I think it's absolutely crucial. Yeah. And if you are, I think, looking at the average K readings over the various millimeters, 2.5 and 3.5, 4.5, and average it out, I think it comes out wonderfully well.
Yes, very relevant. Thank you, team Swapna and Amit. You all did extremely well and good discussions. So we have to go on to our third team. The third team is led by Dr. Gagandeep Brar, a leading pediatric ophthalmic surgeon from Chandigarh, who is going to dwell on my propensity for IOL implants by 6 months of age is very high in pediatric cataract. He is going to be challenged against the motion by Dr. Sujata Guha, an extremely prolific teacher and surgeon, the medical director of Shankar Netralaya, Kolkata. So on to you, Dr. Brar. I think you have to stop screen sharing, Dr. Amit.
He is not sharing, I think.
They stopped already.
Dr. Brar, Gagandeep Brar, you have to share your screen.
Can you see the screen now?
Yes.
Yeah.
Okay. Well, thank you, Dr. Chitra, and I thank the ARC for having me here today. And I'll be discussing why primary implants are my first choice in pediatric cataract by the age of 6 months. Now, the challenge in pediatric cataract is basically successful visual rehabilitation in a child. And along the way, we have to have minimum interventions, risks, and costs. Now, we know that there are practically 3 phases of growth in the postnatal period. And by 6 months of age, more than 50% of the postnatal growth has already taken place. I'll not really discuss this mode of aphakic correction, the spectacles, because we all know with the high powers, the quality of image provided by these and the problems are really a lot. So basically, it is between contact lenses and primary IOS. And contact lenses can overcome some of the problems of glasses, but there is the need of regular cleaning, replacement, so there are logistics and costs. And in our country, also the risk of infections with poor lens care and hygiene. Now, primary IOL implantation is the standard of care for older children. It ensures in the bag implantation in the majority, potentially avoids the secondary intervention in some of them, in the majority rather, and bypasses any appearance of uncorrected aphakia. Now, we do understand that it is technically more demanding and should be done by more experienced surgeons. There are residual refractive errors, and there is the risk of secondary opacification of the visual axis. Now, I'll take you to main studies which compared these two things. The IATS was a randomized controlled trial of 114 eyes across 12 centers. The main thing to see here is that 72% of children in the IATS were less than 3 months of age at the time that they underwent the surgery. And the recommendation of IATS was that less than 7 months of age for unilateral cataract, they would rather recommend the eye to be left aphakic and a contact lens for the visual rehab. Now, going into their data and seeing things a little more in detail, the main reason why they recommended that was because a lot of patients, about 78% of patients in the IOL group needed a secondary intervention, compared to about 21% in the contact lens group, as you see here. But looking at the adverse events, almost 56% of patients with contact lenses had some adverse event compared to 81%. And mind you, we are not yet accounted for all the surgeries which are going to happen when the secondary IOL is going to be implanted. Now, they also had almost 18% of eyes with contact lens related problems. Fortunately, they got away without too much of trouble, but this could have been worse. And also the cost, look at the number of contact lenses which have to be supplied in the first year, almost one per month, free of cost to all the patients within the first year. Now, this has significant bearing in our country. Now, the other study is the IOL number 2 from the British Isles, and they had 221 children, about 50% with IOLs. And they found better vision, at least in the bilateral cataracts, with primary IOL implantation. Almost 3 times better vision, 3 times more children having acuity within normal for age for bilaterals, and double for unilateral cataracts, 10% versus 22%. They did include some of the children who had axial length as low as 15 millimeter for primary implants. So some of that could skew the results towards the worst side. If the axial lengths were more, the results would have been even better. And their interventions for visual axis opacifications were less than the IATS, obviously because some of these children are older than the IATS study. Experience from our own country, Western Indian experience, suggests that children operated within their first year of life have a VAO of something like 20,
1 minute left,
which is less than what we saw in the IATS. And the North Indian experience also shows that consistently the visual axis opacification has been below 20% for most children who have been operated in the first year of life. And even on long-term follow-up, you see visual axis opacification on 8 years of follow-up seen in only 2 eyes out of 26. And in a large series from PGI Chandigarh, consistently, once again, opacification rates below 20% for most children, even when they are operated with the first year of life. Now, this is also borne by a comment from Wilson, who was a leading investigator in the IATS as well, who says that I usually prefer a primary IOL with glasses in any child who is older than 7 months of age. So the primary IOL, even for him, is the first choice by this age. So to summarize, primary IOL implantation is safe in most children beyond months, affords in the bag IOLs and avoids secondary intervention in majority. The logistics, costs, and risks associated with contact lenses preclude their use in a majority of children in our country. And more experience with some of these newer surgical options like optic capture, bag in the lens, etc., and the availability of adjustable IOLs will further increase the safety of primary implants. And I'll just end by showing you a picture of the profile of some of the children and the parents. There's just no way they can use contact lenses over a longer period of time. Thank you so much for your patience.
Thank you, Dr. Brad. That was wonderful. Can we have Dr. Sujata?
Yes, I'll share my screen.
Yeah.
Good afternoon, everybody. At the outset, I would like to thank Dr. Chitra and the AIOS for inviting me to this very interesting debate. Dr. Brar has made my talk easier. He has actually accounted very nicely for the reasons why I would actually take a conservative approach. And I base my experience on two landmark studies, which Dr. Brar has already talked about, the infant aphakia treatment study and IOL under 2. The infant aphakia treatment was a randomized multicentric clinical trial from USA where they actually assessed IOL less than 7 months of age versus aphakia, and they found that the number of adverse events and additional procedures was way higher than the aphakic group. And IOL under 2 was also a prospective non-randomized study from UK, where they assessed 221 children, and they also found that IOL increased the odds of reoperation. And both of them recommended that in very small infants, we should leave these children aphakic. Now we come to the primary question: why do we implant IOLs? We expect a better outcome in children. We expect the glasses, as Dr. Brar was mentioning, to be thinner. Aphakic glasses are not good, he says, and we expect the glasses to be thinner. And of course, second surgery due to secondary IOLs will not be needed. Let us see if we meet these goals. Is the visual outcome actually better? The answer is no. Many studies have found that there are similar visual outcome in aphakic as well as the pseudophakic eyes. But visual axis opacification is significantly higher in the IOL group across boards. It is as high as 45% in most studies. And in cases in countries like India, where we don't expect a very regular follow-up, visual axis opacification can cause a severe drop in vision. Now, are thick glasses really avoided? Well, in children, axial length calculation errors under general anesthesia is very common. And these are more when the axial length is less than 19. And we know the ones, as pediatric cataract surgeons, we know how difficult sometimes it is to freeze these axial length when we have total cataracts in children. Again, keratometry errors are also higher in steep corneas, which is very common in children. And last but not the least, all the formulas that we use are all adult-based formula. And different studies have different formula, which they say has got least predictive errors. So there is no consensus on which IOL formula to use. And coming to myopic progression, that the lesser talked about, the better. It is highly unpredictable. In fact, 3 children in IATS needed IOL exchange because of the high myopic shift. So we really don't know whether this child may end up with a high hyperopia or a high myopic glasses even after we plan pseudophakia. Now for the third question, is the second surgery actually avoided? Well, again, the answer is no. Additional intraocular procedures were much higher in the pseudophakic groups, both in the IATS and in the IOL under 2 studies. And of course, we all know that the infants react much more. Inflammation risks are higher. And glaucoma is definitely more in immature angles, which is very prone to surgical trauma. And there are a host of conditions when we don't implant IOL. Corneal diameter less than 10.5, axial length less than 18, anterior segment dysgenesis, intraop, if your rexus is run off, you have high FEMA. So the cases need to be highly selective if you actually decide to do IOL in these small children. So to summarize, visual outcome remaining the same, so much gray areas in biometry, IOL formula, myopic shift, increased risk of visual axis opacification, second surgery, post-operative inflammation, and very limited cases which are ideal to put IOL. And last but not the least, the surgeon needs to be extremely proficient surgeon with a very nice, very good experience in pediatric cataract surgery. So if I have to err, I would err on the side of aphakia. I rest my case.
Thank you very much, Dr. Brar and Dr. Sujata. Dr. Sujata, I mean, your talks were wonderful and very clear. Dr. Sujata, I have a question for you.
Yes.
You mentioned about IOL exchange. So when would you decide that you've had a big myopic shift? When would you decide, at what age would you wait before you do an IOL exchange?
Well, we basically keep these children hyperopic, large hyperopic, high hyperopic, almost up to 7 diopters. And if we see at the first post-op visit or after 3 months or so, if we find that the hyperopia is very minimal, what we expected, we got a hyperopia much lesser than that, we do follow up these children again with glasses. Whatever Dr. Brar says, we actually follow them up with glasses most of the time, not with contact lenses, especially if it's bilateral. And say if you get some abnormal high myopia at age 5, around -13, -14, it is then we decide to exchange the lens. And remember, these lenses are not as easy to exchange as in adults, because there is so much of fibrosis, we will probably lose the bag.
Absolutely.
I just had one question, and Gagan, Dr. Gagandeep and Sujata, both of you can react to it. If it's a unilateral cataract, the other eye is absolutely normal, would you still not put an IOL less than 6 months?
Can I go first?
Yeah, anybody.
Yeah. So when we decide on IOL, there are a host of things that we see whether it is appropriate to put IOL in these eyes. Especially in unilateral cataracts, we expect PHPV very often. These eyes are a little smaller, so they actually, most of the time, don't fall under the criteria.
Suppose there's no microphthalmia. It's not.
Yes, yes. If I have the surgical expertise, I would actually put. I'm not saying I will definitely close my eyes to it, but I will exercise caution. It will not go across that I will put IOL in all cases. Very selective cases, as you said, this was a selective case. I would probably put IOL.
And Dr. Brar, now this doing posterior optic capture sort of it lessens the chances of PCO. So do you think those, because of these modern changes which have come in, makes you more confident of putting IOLs 6 months or lesser? But then again, if you have a rexis extension, what would you do? 2 questions.
You have to unmute yourself, Gagandeep.
Dr. Brar, can you unmute?
Can you hear me now?
Can
you hear me?
Yes.
The final word is not out whether optic capture is going to be better than in the bag implantation,
yes,
especially when the BPC and anti-vitrectomy has been done. Because there have been studies both ways. Some people have said if you don't do a vitrectomy, there is a pacification of the anterior vitreous, even when you have captured the optic. So you need certain expertise. The surgeon needs to be expert with the optic capture as well. So I would largely be putting IOLs in the bag without an optic capture, and most of the footage which I have shown from the Chandigarh are actually without an optic capture. But yes, there are some studies which say that optic capture is better in prevention of the visual axis opacification, which happens in some of these children. And just a comment on the primary IOL implantation in unilateral cataracts. Overall, across the board, contact lenses, extended wear contact lenses, especially in our scenario, are not easy to use. Because remember, these are going to be children who need contact lenses for almost like 5 years. And people have recommended secondary IOL at the age of 5 years. And Dr. Sujata talked about the great amount of fibrosis which happens. So even when you plan a secondary IOL, it's not easy to implant IOLs into the capsular bag when the capsules are fused and a soldering ring has formed. So the primary IOL, especially if the axial length is more than 18 millimeter, is actually a very good way. And we base our recommendations on a secondary visual opacification. Now we must remember that intervention for a secondary visual opacification is relatively easy, but handling some of these severe complications which may happen with a contact lens are going to be really difficult, especially in our center.
Dr. Sujata, assuming beyond 6 months, there is a rexis extension, what would you do about those cases?
Even beyond 6 months, say 6 is not a magic figure. So in very small children, I would hesitate to put the lens in the sulcus because a lot of inflammation is there post-operatively and they invariably go into optic capture. So if I lose the rexus, I would prefer to keep these children aphakic and go for a secondary IOL. And in secondary IOL, it is not that we always put it in the bag. We have a good rim and it takes about exactly 10 minutes to come in and go out with a neat secondary IOL. And the rate of inflammation as the child grows older reduces. So in the bag placement, yes, we do try, but not very often do we succeed in the bag lens implantation for secondary IOLs.
Just a query in relation to that. I mean, when the hydrophobic acrylic lens is well captured in that capsular bag, would you consider implanting a piggyback IOL for the residual power, because it's easy to calculate? You don't have to remove the primary lens.
Much later.
Once the power is
yes.
stabilized.
See, in children, we actually are very conservative. Usually, if I have to do an operation on a child, I would think twice. Yes, at a later age, piggyback lens, if the first lens is in the bag, is definitely an option at a later stage.
But there are not too many. We don't have too much of data in children with piggyback.
You're right. You're absolutely right. Because we wouldn't actually jump in and go ahead and operate in children. We would rather put them on glasses and let them go through their childhood, adolescence with glasses.
Oh, I'm talking about once the power is stabilized, maybe even at the age of 17 or 18. Once the myopic that occurs in the second decade has also stabilized.
Yeah, absolutely. Piggyback lens is a possibility. Absolute possibility in case you have a neat lens in the sulcus and the sulcus is actually well formed. It's no glaucoma. See, we have so many things which can go wrong with pediatric cataract. If the child does not have a glaucoma, if the child has not got a fibrosis, if the child has not got optic fracture, if all of them are neat and clean, why not? Yes, we can.
Can I add one thing?
Yes, yes.
I just want to ask one question to Sujata as well as Brar, because the first opportunity is the best opportunity as far as the pediatric cataract is concerned. You want to put a lens in the bag, I think the first opportunity is the best. And you want to leave this because these children are going to live for 80 years or 85 years or whatever it is. But you're going to do a secondary implantation, you're going to leave the lens in the sulcus forever. So whether to put the lens in the bag, because I put the lenses, most of the patients I put the lenses as much as possible, I try to put the lenses in the primary implantation itself. Especially for unilateral congenital cataracts, as Namrata said, very dense amblyopia, very difficult to treat. I definitely put the lenses. Unless otherwise there's a contraindication like an anti-segment dysgenesis or the corneal diameter is less than 10.5 millimeter or there is a PHPV or something like that.
I think they have answered this question already in the earlier part that majority, we'll have to really screen these patients before we take a call, I think.
Absolutely.
Yeah.
Absolutely.
Thank you very much, your team. It was really good. We learned a lot. So we shall now go on to our next team, Dr. Srinivas.
Yes, ma'am.
I would want my speakers to stay on and enjoy the whole debate. Yeah.
Here comes the fourth team, is led by, I call him as a 4D man. It's not just 3D. It is dashing Dr. Deven Tuli from Delhi. So he's a senior glaucomatologist and he'll be speaking on early lens extraction. He's the treatment of choice for angle closure glaucoma and suspects. So he'd be contesting against another young dynamic glaucoma surgeon from BBI Foundation, Kolkata, Dr. Manish Singh. Over to Dr. Deven, please.
Yes, thank you, Srinivas. I'll just... just introduce these terms for the audience. PSCS, PSC, and PSCT as per the new classification. PSCS is when you only have narrow angles. And without a doubt, in these cases, an early lens extraction is going to help the most. Even in a borderline situation, when the borderline cataract, I would define it as 6/9 or 6/12 vision, in which you otherwise don't want to operate at that time. I think if there is a borderline cataract and a situation of a suspect or narrow angle, you can advise your cataract surgeon, or if you're a cataract surgeon yourself, you can go ahead with doing an early lens extraction. PAC would be when you additionally have goniosyne K as well as when the pressure is up. So in addition to narrow angles, you have these two. And in this also, with a borderline cataract or a significant cataract, lens extraction is going to help definitely. But in these situations, you must inform the patient that the patients may need 1 or 2 meds to supplement the situation, the early lens extraction. In PACG, in addition to all these, you will also have optic nerve damage. And this sometimes is in the older classification was referred to as chronic angle closure. It may be moderate or advanced. And keeping that in mind, yes, lens extraction is going to help in these situations also, but the patient may need meds or a trab to define the target pressure or achieve the target pressure. However, I must tell the audience that we are not in favor of doing a clear lens extraction. It is okay to do for a borderline cataract, but don't do a clear lens extraction. The guidelines are not there to safeguard you in case you have a problem. The meta-analysis of a number of these studies, and also involving the EAGLE study, has shown the lens extraction is the way forward, definitely because in pupillary block, as you will recall, the lens is offering the support to the iris that actually causes the pupillary block. And if you can remove the lens early, then the pupillary block element is taken care in a number of situations. However, in the last few years, we have now realized that angle closure is not just about pupillary block. About a third of the situations will have a non-pupillary block element also, in which the lens is the main culprit. It may be in terms of the lens thickness or the placement or both of these factors. And in these situations, a YAG PI alone may not help. So the lens has to be out for these. And I remind you, these are there in about 1/3 of situations. Also, a lens extraction is going to help because in advanced glaucoma or a moderate or the chronic ACG or the PACG that I talked about in the last slide, if you do only a trap and if you don't tackle the lens at that time, what will happen is that these eyes already have an shallow AC. And if the trap, the shallowness of the AC is further confounded by a trap, then the cataract progresses very fast. So much so in some of these patients, the second surgery or the cataract extraction is required sometimes in the first 2 or 3 months itself. And that causes, taking the patient to the OR a second time, and also it causes fibrosis in the blood that you've created first. So in those situations, yes, there may be a case for doing a lens extraction also. In synecholysis is a technique which a lot of our colleagues in India are not doing as yet. So if you are doing Phaco or an SICS, then you can additionally do a goniosynecholysis. And this is the work from Robert Rich from New York. He has shown that in these situations, even a primary angle closure in which there was synechiae, but the optic nerve damage was not there, a goniosynecholysis plus a lens extraction may be the treatment. So I'm going to summarize my case in favor of lens extraction by saying that we are not in favor of doing clear lens extraction. Lens extraction is anyway needed in about 30% or 1/3 of the situations. But in suspect cases in which only narrow angles is there, it may work in even up to 70% situations. Please remember that angle closure glaucoma spectrum makes up half of all adult glaucomas in India. And there is no one in the audience who's going to debate this point that cataract surgery is done more often than YAG PI is done by general ophthalmologists. And as a glaucoma person, I'm very happy in saying this because some of them don't even do gonioscopy. They don't even realize that the angles are narrow, but they go ahead and doing a cataract. But in that, with the lens extraction, the angle closure element is also taken care of. So I'm going to say this, that it may act glaucoma surgery lens extraction and may be a great tool for the Indian scenario as a whole. Please remember, lens extraction is okay, but you must follow up the patients as you do with the YAG PI, and some of these in future may need medication and trab to achieve the target pressure. Thank you, ma'am, for including me, and thank you to AIOS.
Yeah, very crisp talk. Very good, Dr. Devan. On to you, Dr. Manish. Let's hear from you.
I'll just unshare, ma'am. Just allow me to unshare. Yeah, go ahead.
Good afternoon. First of all, I'd like to thank Chitra Madam and team ARC for this invitation. So there are a few points I'd like to highlight. One is early lens extraction is a treatment of choice for angle closure glaucoma and angle closure suspects. So I'll be speaking against it. There are two important points I have highlighted: the treatment of choice and angle closure suspects. We first need to understand treatment of choice is a very important term. It basically means the best available treatment. So are we trying to justify that the best available treatment for a glaucoma suspect is lens extraction? Are we really serious about it? Because if you see what Dr. Tuli was also mentioning, that angle closure suspects are just patients where they don't have glaucoma. The optic nerve is normal, the field is normal, the pressures are normal, there are no synechia. They basically just have, say, 180 of iridotabular contact. These patients, if you see in our population, almost 1/10 of our population above 45 years actually have these angle closure suspects. So if you start knocking off these lenses, we'll be doing crores of cataract surgery. And if you see the major studies like the Velorise study and the ZAP trial, they have shown that the majority of these angle closure suspects will never develop glaucoma in their lifetime. So these patients, most of them actually don't even require an iridotomy. Forget about going for a lens removal. So what I want to highlight is that we should use the right weapon for our patient. For example, if you want to kill a mosquito, you use a hit and not your sword. Coming to the Eagle trial has got different interpretations. It's like the blind man and the elephant. Eagle trial, the point that has been highlighted that is gives you a better IP control and a better quality of life. But we need to understand Eagle trial was done only for patients with primary angle closure more than 13 millimeter mercury IOP and early PSCG. So Eagle trial study cannot be applied to all types of glaucoma. They are specific for this group. Plus about IOP, Eagle trial has shown that the difference of intraocular pressure between iridotomy and lens extraction was just 1.18 millimeter. And they had mentioned in their method that unless you have 1.75 millimeter mercury of difference of IOP, the difference will not be significant. About quality of life also, there was a minimal difference in the two groups. That also because of the improvement of the refraction status and because of contrast sensitivity. But the lens extraction patient had the loss of accommodation. Eagle trial has a lot of fallacies. For example, almost 50% of the patient, there was missing gonoscopy data. And Dr. Tuli has already highlighted why gonoscopy is so important in these patients. Complication, we all know that early lens extraction has a lot of complication because these are patients with shallow chambers. A lot of them will have zonular weakness, high vitreous pressure. There is risk of DM detachment and corneal decompensation. So it's very difficult to justify a cataract surgery for a patient with a 6/6 and 6 vision purely for opening of the angles. When you have something like a laser iridotomy, which is time tested and safe. So my take will be that lens extraction at max can be an option, not the treatment of choice for patients with early PSCG or primary angle closure with IOP more than 30 millimeter mercury as included in the Eagles trial. But yes, definitely cataract surgery has a role in angle closure. It will improve your intraocular pressure and there is opening of the angle provided there is not extensive synechia. At the same time, there are reports that post-cataract surgery IOP may increase also. Like Singleton et al. Has shown that more than 15% of the patient had more than 30 millimeter IOP on day 1. Plus, Lee et al. Has shown that in their patient with PSCG, even after cataract surgery, 25% patient continue to progress. So you have done a cataract surgery, you have opened an angle, that doesn't mean the glaucoma may be taken care of. You still need to monitor this patient. You may still require glaucoma later on. So what we need to classify is that what is more important for a patient? Is the cataract extraction or the glaucoma? Or rather, what is more important, IOP control or the visual rehabilitation? These are the three most common procedures which we use for our angle closure glaucoma patient. So, and IOP control wise, Phaco surgery definitely is inferior to trabeculectomy and a combined surgery. But yes, it has got less risk of complications. So the important points to consider: have a proper preoperative gonoscopy, look for extensive synechia, see the stage of disease, and what is your target intraocular pressure. If the patient is having visually significant cataract, IOP and fields are well controlled with less than 2 medication, just the lens extraction will be fine. But in case the IOP control is important, patient has high pressure with insignificant cataract, go for trabeculectomy and a lens extraction after 6 months. But if there is a significant cataract with a moderately advanced glaucoma and patient needs more than 2 vision, going for a combined surgery will be best. So I conclude that for a patient who are suspect, laser iotomy is a treatment of choice, not the lens extraction. And angular glaucoma patient, lens extraction is one of the multiple treatment options, not the treatment of choice. And we remember that lens extraction for all and closed angle will be like doing a CABG surgery for all angina patient. Let us not go for overkill. Thank you so much.
Thank you, Dr. Manish. That was a very, very clear talk. Srinivas, you want to ask your questions first?
Yeah.
Yes.
You can go ahead, madam.
Dr. Manish, it's a situation that a person needs a trabeculectomy and there is a lens sitting there. It is maybe not even borderline cataract. And it's a hyperopic patient. Even in those situations, you still would want to do a trab alone. You won't want to remove the lens. Because as you are actually challenging yourself for a future cataract surgery because the eye is going to be small.
You have to see, as I mentioned, what is the main aim. If the patient is having very high pressure, say patient is having 30 pressure, 28 pressure on 4 medication, there the primary aim is to control the intraocular pressure. If the patient is having early cataract, as Dr. Tuli was also mentioning, I'll consider removing the lens. But if there's a clear lens, I'll just straight away go for a trabeculectomy and try to control the pressure first, because doing a combined surgery generally has a lesser IOP control compared to doing a trabeculectomy alone.
Dr. Tuli, you have anything against it?
Yeah, ma'am. So clear lens, no. But yeah, if it's early cataract and the AC is shallow in a hypermetrope, like you said, there would be a case for considering it. But we have to discuss this individually with the patient. So informed consent is a must.
And if a person looks like it's going to be a non-progressive disease, you mean to say if there is a borderline cataract, you will do a Phaco or you would not do a YAG-PI? Because I want the attendees to go with a clear message. Now we are out of the debate.
Yeah, so ma'am, if the cataract, if the patient is being considered for cataract on the discretion of the surgeon, then YAG-PI may not be required provided the surgeon is confident to operate in those settings. That means if you dilate the pupil for cataract surgery and a YAG-PI has not been done, the pressure may rise during surgery or there may be upthrust. But usually, yes, I think we are all confident cataract surgeons now. Usually, alone a cataract surgery would suffice in that patient.
I think
so. It would be, 2 hits, treating 2 things with 1.
I think this is a very, very good topic for the debate, madam, because it's a very controversial topic, whether to do clear lens extraction in these cases or not.
Not clear lens extraction.
Clear. I think I said very clearly.
David is very clear about it.
It's not early lens extraction.
He's not talking about clear lens. Nobody is talking about clear lens.
But no.
We don't want to do few colors operation at all, Srinivas.
No. When it comes to the Eagle study, which has raised all these controversies and which has led to the debate, which has shown, and the majority of the surgeons, I think you also believe in the Western world, are doing CLE as the matter of choice in these patients. But in India, I think it would be difficult. We don't want to be so traumatic or earlier try with, as Dr. Manish said, iridotomy or do a goniosynovial lysis and then go ahead with the cataract extraction. Then why would this Eagle study would even stand?
Yeah, so I think there have been studies which have been modeled in India based on so many other studies, not just Eagle. And I think one of them was from RP Center from Professor Dada. And I think the results have been at par at the most. So clear lens extraction, no, I think we still don't want to do. You can't model everything which is done in the Western literature for India. That is the message.
Yeah, it has to be customized for their own set of patients.
Dr. Mohan, you had anything to add?
Absolutely. I think Devan and Manish were very clear in whatever they wanted to say. Yes. Clear lens extraction is not an indication for clear lens this thing. That is not the what we are talking about. That is an indication for iridotomy or a goniosynovial or whatever it is. But if a patient is an elderly patient coming with an angle which is narrow, hyperopic patient, the lens is going to be definitely thick. Okay. Yes. If you see on the OCT on this on the catalyst, you will see these lenses are very, very thick, and lenses are also positioned more anteriorly as well. And these are the absolute indications, in my opinion, for lens extraction. And once you do a lens extraction, Phaco, and put an IOL, and the glaucoma is gone forever.
Yes.
Yeah.
Yes, I'm sure Dr. Devan and Dr. Manish agree on that.
Yes, sir, definitely.
Yes?
Anything Mohan sir says, we have to agree.
Devan, you are the authority.
No, sir. Yeah, I think, sir, it's agreed that the situation needs to be individualized. There is no case for doing a clear lens, but yes, in a early 6/9 or 6/12 vision worthy cataract, I think we can go ahead with doing an early lens extraction than otherwise in those cases, and that may be the treatment for the cataract as well as for the early angle closure.
No, surprisingly, Chitra, nowadays we are seeing more patients in this category. Patients who are coming with a shallow AC, with a thick lens, and older patients.
Lens.
I think it's absolute indication for this Phaco for this patient.
Yeah, those are like I said, are individual cases, but they don't fall into a large category. Like I said, they may be about a 1/4 or a situation, but the message to the audience should not be that they start doing clear lens fake or SICS from tomorrow.
The one more point I like to add, which Dr. Tuli was also mentioning about the gonioscopy. We have seen patients where there is a early cataract with 360-degree synechia or more than 270-degree synechia. We thought the cataract surgery might help, but post-surgery we have seen the IP is just same. There is no improvement of the intraocular pressure. So a gonioscopy can give a lot of information. If you have an appositional closure on compression, the angle is opening up. These patients generally do well post-cataract surgery. But if already extensive synechia has formed, these patients will do better with a combined surgery. So a proper gonioscopy can definitely give us a lot of idea, along with the, as sir was mentioning about bulky lenses and shallow chambers.
Thank you.
We have all been mentioning only about clear lenses and cataractous lenses. I think now we all agree that there is also an entity called dysfunctional lens. And we have a dysfunctional lens index, which we routinely measure with the eye trace. A 52-year-old with a shallow anterior chamber, with a fair amount of cataract, with a hyperopia about +2, 2.5. To extract these lenses and put maybe a trifocal lens or something, these patients end up with very successful results, and the chance of landing it with a glaucoma later on also goes away. So I think this is just an additional point to keep in mind.
We shall now go on to our next team because we really are running short of time. Our fifth team is led by Dr. Jaspreet Singh, a young neuro-ophthalmologist from PGI Chandigarh, who is going to be talking on all cases of optic neuritis should be extensively worked with imaging and blood studies. He is going to be contested by Dr. Mahesh Kumar, who heads the neuro-opthal department of Arnindai Hospital, Madurai, a very eminent teacher himself. So on to you, Dr. Jaspreet. I think we'll have to stick to just one question each.
Yeah. I'd like to thank Dr. Chitra, ARC and Team AIOS for extending this invitation to be part of this interesting debate. And I would be speaking on whether patients of optic neuritis should be worked up extensively. Yeah, so optic neuritis is no doubt a clinical diagnosis. For making a diagnosis, you really don't require any imaging. But what happens next? The older paradigm was you have a young female RAPD with visual loss and a normal fundus. You give IV steroids, and that was it. Because earlier there was nothing for MS. Until the treatment for MS came, that is when the ONTT came into existence in the New England Journal of Medicine, where they showed that brain MRI is crucial in stratifying the future risk of MS in patients of optic neuritis. So every patient, they would advise a contrast-enhanced MRI to see for any periventricular white lesions. So if it was negative for MS, they may or may not would prescribe steroids. They did say that steroids would not change the final outcome. So what is optic neuritis, the etiology? It's not just MS. You have such a varied causation of optic neuritis, demyelinating lesions, which are the commonest like MS. You have axonal loss like neuromyelitis optica. Then you have certain other autoimmune diseases which cause optic neuritis. You have infectious, para-infectious, inflammatory, paraneoplastic diseases. All these can cause optic neuritis. But yes, I would be stressing on just the commoner causes, which are the demyelinating lesions. So we in these few years, I mean, after 2004, there have been the discovery of new glial antibodies like anti-MOG, aquaporin 4, glial fibrillatory acidic proteins. This has really helped us understand the disease because there is a clinical overlap between a typical, which is an MS related, and a non-MS related optic neuritis. So how do we differentiate between the two? When there's so much ethnic variation, when you see the neuromyelitis optica in 20 to 48% of Asians and just 1 to 3% of Caucasians. So the only way to differentiate between them with affirmation is to investigate. And why we need to investigate? Because the management and the prognosis for each subset is different. Now, is every optic neuritis MS? The latest criteria for diagnosis are based on investigations. You have to investigate. The McDonald's criteria in 2017 had MRI features as the key to define the risk of MS along with or without CSF band. So with all this, a misdiagnosis can be avoided. So what's the difference between an MS-related optic neuritis versus a non-MS? I mean, there is so much overlap between the phenotype. It could be unilateral, it could be bilateral. The severity of visual loss can vary from mild to severe. So with so much of overlap, what do you want to see? You want to investigate them, whether there are any lesions which are typical on MRI. What is the optic nerve involvement, whether it's anterior, whether it's middle, or whether it involves the posterior part or the whole part, whether it's extending to the chiasma, whether the spinal cord is involved, whether there is any tissue destruction and cavitation. MRI would give you an answer to all these things. And yes, with the evidence of biomarkers, things have started to change. So the red flags in optic neuritis, where you can advise, I mean, what's going on, how aggressive your management should be, are based on bloods and imaging. None of the clinical presentations are diagnostic for the atypical variety of optic neuritis, and if the antibodies are not detected. Conversely, the continuum of this NMOSD, that's a neuromyelitis spectrum disorder, can be wider based on the presence of aquaporin 4 IgG antibodies in milder spinal cord syndrome. So you need to investigate if it's, I mean, because it can go anyway. Then the antibodies are associated with similar syndromes. So neuroimaging finding of MS do not necessarily exclude the diagnosis of NMOSD, as they can occur in patients who are seropositive. So again, an overlap, you need to investigate. The treatment is very different, both of them. The chronic treatment is absolutely different. So you have to have a real diagnosis. So MRI brain can be normal in MS and NMO spectrum. Imaging should be added to these. With such a variable spectrum of optic neuritis and systemic etiology being associated, testing should be mandatory in all cases. And I like to conclude here, in the era of biomarkers, the way we look at optic neuritis has changed. The pattern of optic nerve enhancement on MRI provides diagnostic clues to etiology. It helps us to understand the mechanism of the disease, thus influencing treatment. And with such a phenotypic overlap between multiple sclerosis, aquaporin 4, neuromyelitis spectrum, MOG, and other autoimmune diseases and paraneoplastic syndrome, it is important to appreciate that they are separate entities with differing prognosis, underlying pathophysiology, and most importantly, we have optimal treatment for them. So we should investigate all cases of optic neuritis. Thank you so much for your hearing.
Thank you very much. On to you, Dr. Mahesh. It was a very nice talk.
Beautiful. He's covered everything.
Mahesh, are you muted?
I think I'm sharing my screen.
Yes, yes, we can.
Okay. First, I would like to thank for the opportunity by Dr. Chitra Ramamurthy, the AIOS and the Academic Research Committee for having invited me here. So I'll be following up on Dr. Jasprit Singh's talk on every case of optic neuritis should be extensively imaged and investigated, and my answer is an emphatic no. So I'll be focusing on certain points which are pertinent in this discussion. I'll be focusing on every case. What we are discussing is every case and not selective cases. So I'm against investigating in each and every case. And I'm also against extensive testing. I'm not against basic testing, but I'm against extensive blood workup, which has its own cost issues and other factors which we will be seeing, which involves a lengthy blood workup. And I'll also be contesting against a lumbar puncture and CSF analysis in every case. Like Dr. Jasprit Singh himself was mentioning about the McDonald's criteria. which told that MS can be diagnosed by means of MRI with or without CSF findings. So in the first instance, we do not need to do in the initial workup itself. So one thing I will not be contesting against Dr. Jasprit Singh argument is the need for a contrast enhanced MRI, brain and orbits in every case of optic neuritis, and I'll fully go with them because it's a very mandatory requirement. One caveat in this, supposing the patient is not able to afford in extreme cases, at least a CT scan should be done in case of cost issues, but no imaging is not acceptable. So while arguing this, I would like to call upon the natural history of optic neuritis as per the optic neuritis treatment trial. We know that majority of the typical optic neuritis as per the ONTT recover on their own or with steroids. And they've also found that blood investigations, routine blood investigations, are not helpful in diagnosing or characterizing this optic neuritis. However, I will not contest the fact that a basic blood workup, which is relevant to steroid use in these cases, need to be done like a blood sugar or other basic investigations. And secondly, I would like to characterize what an atypical optic neuritis is, which might require extensive blood workup. So there are clear definitions for atypical optic neuritis, and these are all recurrent optic neuritis, steroid responsive optic neuritis, meaning that they dramatically respond in 1 or 2 days to 6/6 with IV steroids and eventually become steroid dependent because of that, and bilateral optic neuritis, and those presenting with bilateral optic disc edema. These are all classic definitions of atypical optic neuritis. And in these cases, I am not contesting that we need to extensively investigate these cases. Also, there are clear-cut radiological findings of atypical optic neuritis, which may alert us initially to the suspicion of atypical optic neuritis and the need for extensive testing, like bilateral lesions like this. In these bilateral granulomatous lesions, you can see here, these are sarcoid lesions. And by seeing this imaging itself, we know that we need to investigate for sarcoid, other autoimmune disorders, and perhaps for neuromyelitis optica and anti-MOG. Long segment involvement, more than 50% of the optic nerve involvement. By seeing the radiology itself, we know, okay, this is something abnormal. It is extending more than 50%. Perhaps the intracanalular as well as the intracranial part and perhaps the chiasmal part, if they get involved, we know it's abnormal. In radiological parlance, they term it as long segment or longitudinal involvement. That's what they call it as, more than 50% involvement. Optic perineuritis is another atypical feature. You can see here, the nerve in the center is clear, whereas there is enhancement of the sheath surrounding, something like a tram track sign, where we might confuse this with meningioma. Yes, yes, optic perineuritis, and also longitudinal extensive spinal cord lesions. In selective cases, when we do spinal cord screening, and if we find this, we know that these patients have to be extensively investigated. So I would like to support my findings with two specific Indian studies, important studies by Dr. Rohit Saxena from AIOS, who studied 99 eyes of 83 patients over a period of 3 years, and they were followed up for about 10 months. And in their study, all basic blood investigations were normal. They did not yield any specific specific results, and recurrence was found in only 16% of the cases of retrobulbar neuritis. 85% did not recur in their case, and 64, majority of the patients recovered with 20/40 vision or more. In another retrospective, another Indian study from a South Indian demyelinating disease registry from Mangalore, 59 patients of first presentation optic neuritis were studied, and they found that 14 patients were monophasic, did not progress. 29 patients developed MS. Again, these did not require extensive blood investigations, and only 13 plus 3, 16 patients required extensive blood investigations. 3 were MMO and 13 were CRAYON, meaning chronic relapsing inflammatory optic neuritis. They only needed extensive blood workup, and only minority of these patients needed extensive blood investigations. So to conclude, I would like to say, if routinely we treat this as optic neuritis with IV steroids, and if they don't recover, we investigate further. If there are recurrent attacks, we investigate. And if there are long cord lesions in MRI, we investigate. And we focus our investigations on the relevance of the investigations. We also have to think of the resource utilization and the time factors involved, and not the least in our Indian setting, the cost factor to the patient has to be kept in mind. Thank you very much for the opportunity.
Thank you, Dr. Mahesh. That was a big learning. Dr. Jasprit, I wanted to ask you, said, moving out of the debate, it seems to come clear that an MRI per se itself might guide us whether we need to investigate further or not. Would you, assuming that you also realize that you, just for the sake of the debate, you demanded all the investigations, would you want to do just an MRI alone, or would you like to combine it with spinal at least, a spinal examination at least?
So again, it's basically the clinical spectrum what we see. I mean, there's a lot of overlap in the conditions which we see. I mean, just having a disc edema, which is not typical of MS, but you might have disc edema in the MOG-related disease, but you can have a disc edema in MS as well. So MRI is a must, but MRI can be negative in atypical optic neuritis. It can be negative in MS. So what do you do then? You will need to investigate these patients. You don't want to miss the boat. Time is vision in optic neuritis. You want to investigate and then aggressively manage these cases.
And Dr. Mahesh, to you, would your management change if this is the first episode of anti-MOG related optic neuritis? Or would you follow the same protocol which you mentioned?
Even if it is MOG, they are quite steroid responsive, and I would follow the same protocol. However, if it is neuromyelitis optica positive, aquaporin 4 positive, then following steroids, we immediately refer to the neurologist to consider immunosuppressive therapy.
Thank you very much. We could go on. It's a very interesting topic. I think I'll go on to the next speaker.
Madam, one quick question.
I want to just give Chitra.
Yeah.
That MRI brain, orbits, and spine has to be taken for all these patients. Many of them do.
What I wanted to tell what Mohan sir is telling. Mahesh sir, I just wanted to know, do you do MRI in all your cases?
Yes.
Or do you still have some reservations in the very selective, clear-cut, clean case where you know that there is a color vision loss? It is a case of optic neuritis. You don't want to investigate further. I'm just asking the imaging studies, not the blood workup or the lumbar puncture.
No, if clinically, if it is optic neuritis and we have a strong suspicion of optic neuritis, we do in 100% of the cases, unless the patient cannot afford, and we try to do at least a CT, but we have to do in all the cases. If clinically,
one case, sir, having mucormycosis, he did not reveal it. And one dose of IVMP, it really blasted and it caused a total ophthalmoplegia. I think MRI, it comes as a savior in these cases. If there is rest of any other abnormalities before giving this high dose steroids, it will pick up. Otherwise, the infection will spread rapidly.
No, Mahesh, I want to ask, what is CT going to reveal in these conditions?
CT will reveal, like I was telling, that any infective cause like sinusitis or any other compressive lesions, they can also mimic retrobulbar neuritis. Like even a pituitary adenoma is presented to us mimicking retrobulbar neuritis and meningiomas. So only in the extreme situation, we are going to resort to CT. We'll try our best to do an MRI. CT will at least tell us that there is something else which we should not miss before giving IV steroids.
Exactly. Dr. Mohan Rajan correctly mentioned, I mean, cervical spine is important. You have a negative brain MRI, but you have cervical spine, one segment involvement or 3 segment involvement. Then you can tailor your diagnosis on what you're dealing with, typical MS or non-MS related.
Can I just ask a question, ma'am?
Yeah.
In a known case of MS, would there be any protocol for monitoring that you would advise the patient? Or in a case of blurred vision, in a known case of MS, how fast would you do a MRI or anything else would you add?
Yes, so for a known case of MS with optic neuritis, it's recommended probably a yearly MRI for 5 years. And for the first time presentation, again, you have to do imaging to know what it is.
Yeah,
If
definitely.
If it's characteristic MRI changes probably then. But still, I mean, you have to be careful. You don't have a perineuritis or you have a massive disc edema in an eye with the MRI changes suggestive of MS. Again, you have to keep another diagnosis in your mind. It can't be just going ahead with MS.
Thank you.
Thank you very much. And we move on to the next team, the 6th team. Yes, madam, I'm here. The 6th team is being debated by Dr. Ashish Kumar, a young cataract and cornea consultant from Patna, which is now the hot seat of India as it is going for elections. And we'd like to contest with Dr. Jayesh Wazirani, a proficient and young cataract and cornea surgeon who will be talking on for Fuchs and cataract, a combined procedure, versus Dr. Ashish, who will be saying, no, it would be staged procedure. Over to Dr. Ashish, please.
Dr. Namrata, we'll be needing you to
Thank
comment
you.
on these cases. Yeah.
Thank you so much for the invitation. It's an interesting debate going on, learning a lot. We encounter these cases every day and there's a lot of confusion. Thank you for conducting this. My topic for today is Fuchs and cataract, and my treatment of choice would be stage procedure always. My slides are visible?
Yes, sir.
Yes.
All right. Okay. So look at the possibilities of doing a stage procedure. It gives you enough, it gives you enormous possibilities. Like if the patient has just a cataract and not much of Fuchs, not causing much corneal edema, you can just do a cataract surgery. And if required, DMEC and DSEC can be planned at a later stage. And then if needed, cataract surgery at a second stage, especially in younger people. And there are certain cases like where you have a severe subepithelial fibrosis and you like to do a superficial keratectomy before you do a DSEC and DMEC. So if you do a stage procedure, you can do all this. So biggest advantage of the stage procedure is that you may never need a second stage of the surgery. And with the Descemet's stripping only and Rho kinase inhibitors, these patients may never need a keratoplasty at all. So the most important thing is what is the timing and the type of surgery you do. Success and safety of endothelial keratoplasty has resulted in lowering of the threshold for intervention compared to when PK was the surgery of choice. Nowadays, people are doing EK for just removal of the guttae. And this was not possible when PK was the only choice. Still, we use central corneal thickness and endothelial cell count as a surrogate marker for endothelial cell health. And this is how we decide whether we want to do a combined surgery or a stage procedure. But this at times can be misleading. This is a specular image from a single patient. If you see three different places, you have three different readings. So you cannot rely on specular images for deciding cataract surgery or a combined surgery. So recently, Scheimpflug tomography has been considered to be the most relevant indirect measure of endothelial corneal health. CCT, like I said, is used as a guide, and it is seen that if the CCT is more than 640 microns, there's an increased risk of postoperative corneal edema. So if it is more than 640 microns, one-fourth of the patients will need keratoplasty after cataract surgery. But see what you're doing. Almost 3/4 of the patients who may never need a keratoplasty are being subjected to the lifetime risk of graft rejection. So never a combined procedure. Always do a stage procedure and see what happens to the cornea. We can always go back and do a cornea procedure. Obviously, combined surgery gives you certain advantages like less number of surgery and less number of anesthesia exposures. It's a cost-effective and faster visual rehabilitation. But you have to look at the other side. And several studies has compared sequential procedures with triple DMEC, like endothelial cell loss and visual refractive outcome, re-injection rates, and primary graft failure did not differ much between the two. But the main concern with the triple DMEC is the use of viscoelastics during the cataract surgery. And this is the main reason for graft detachment. See, re-injection rates can be brought down from 45% to 16% with the elimination of complete viscoelastics during graft injection. This is only possible when you're staging the two procedures. Because in DMEC, if you're just doing DMEC without cataract surgery, there's no use of viscoelastics. This was a case of, I planned for SICS and DSEC, because the cataract was very dense and the pupil was not dilating. It was a PXF. And I thought I'll get away with a small pupil. I didn't want to do any sphinctotomy here because the iris will get floppy and then it'll mess up air injection. Sometimes air will go behind and then the iris will stick to the cornea. So I thought of doing a larger excess under the pupil, and somehow I managed to do it. But see what happened next. The cataract was very hard and I was just struggling to remove it from a small pupil. So this was
1 minute left.
And then I left with no bag. So I have to cancel the surgery. So what are the advantages of lens surgery without keratoplasty? Most importantly, you may never need a keratoplasty. You can put IOL of your choice, toric and multifocal. It's still debatable, but toric is acceptable. You have the opportunity to do PI, which sometimes during combined surgery can cause bleeding, and unfolding of the DMEC scroll will be difficult. You have shorter surgical time, and you can get away with intraop complications like PCR if you are just doing lens surgery. And the advantage of DMEC without lens surgery, you preserve accommodation in younger patients. Otherwise, these patients will have to wear glasses at a very early age. This is a case of Fuchs with cataract. And I did the cataract surgery a couple of months ago, and then I planned for DMEC surgery, and I'm doing DMEC stripping under the saline. And see, here I have done the PI already while doing the cataract surgery. So there's no bleeding while doing second stage of the procedure, DMEC. Then securing the graft, putting the graft inside, unscrolling the graft with the tapping technique, just a 15-minute procedure. And you're done with the. So when to do DSEC and DMEC? Again, now the DMEC is the procedure of choice. When the patient is phakic, you like to do DMEC because you want a shallow anterior chamber. If the patient is pseudophakic, you have a deep AC, you can either do DSEC or DMEC. The procedure of choice is DMEC again now. So my guide to Fuchs and cataract: grade the severity of Fuchs and cataract, try to correlate the symptoms with the sign. If the patient is complaining of just a generalized decrease in vision, just go ahead and do with the cataract surgery. If the patient is complaining, he has a diurnal variation, then do keratoplasty first and then later plan for cataract surgery. Consider the age of the patient. If the patient is young, don't touch the lens, and then determine whether cataract surgery is needed or keratoplasty. So Fuchs and cataract, it's always staged procedure, never do a combined procedure. Otherwise, you'll be subjecting 3/4 of the patient who never need a keratoplasty. You'll be subjecting them to the risk of graft rejection. Thank you. Thank you so much.
Thank you, Dr. Ashish. That was a wonderful talk. Dr. Jayesh, can you share your screen? You have to unshare, yeah.
Yeah. Is the screen visible?
Yeah.
Yes, yes.
So thank you to the committee, particularly Dr. Chitra, for the invite to speak. And the topic assigned to me is Fuchs dystrophy with cataract. So in this scenario, we presume that as there is a cataract, and as surgeons, we don't do surgery in an eye with cataract without removing the cataract. So the only question remaining is whether to combine the cataract surgery with a corneal procedure or not. And I'll just try to simplify when and why we should do combined surgery. So when a patient with Fuchs dystrophy and cataract presents to me, these are the 3 questions that I feel we need to answer. And if we have satisfactory answers to these 3 questions, the decision-making becomes very simple. And essentially all medicine and all surgery is good decision-making. So the first question is, does the patient need a transplant procedure at present? That is right now. Is a corneal transplant indicated? We are, of course, knowing that all these patients do have cataract coexistent with the Fuchs dystrophy. So some cases, the decision-making is fairly simple. So if we have a patient with an eye which looks like this, in this case, I know that the lady has Fuchs because the other eye has less advanced Fuchs dystrophy. It's obvious that this eye needs a corneal transplant procedure, and therefore you need to combine a corneal procedure with a cataract surgery. You can't just do cataract surgery in such an eye. Other cases are less obvious. Nonetheless, we have plenty of clinical signs which help us decide that the cornea has lost its reserve of functional endothelial cells and therefore needs a transplant procedure. The most prominent signs being presence of stromal edema, epithelial bullae, and areas of irregularity and confluent guttae, which are very prominently visible in retroillumination. So this patient, again, with Fuchs dystrophy and cataract, it's a no-brainer that you need to replace the endothelium and you also need to do cataract surgery. Likewise, this patient of mine who, in addition to Fuchs dystrophy and cataract, also has microcornea and a cornea plana, we can see very clearly on retroillumination that there are profuse guttae, there is stromal edema, and therefore the cornea is already starting to decompensate. And you need not worry whether or not the patient needs a transplant. The patient definitely needs a transplant in addition to cataract surgery, as doing only cataract surgery in the presence of corneal edema is only going to worsen the corneal edema. So the first question to answer is, does the patient need a transplant procedure at present? The second, and this question is more pertinent and more difficult to answer, is the particular patient likely to need a transplant procedure in the near future? So these are the cases which do not have clinically obvious corneal edema, have Fuchs dystrophy, and have cataract. And these are the patients where decision-making is a tad tricky. So let's say this patient, which the eye is showing a lot of guttae, the patient has Fuchs dystrophy, the patient has a cataract, but there's no clinically obvious edema.
So is this patient likely to need a transplant in the near future? If the answer is yes, then of course we would like to combine the two procedures. If, however, the answer is no, then it would make sense to do the cataract surgery with adequate precautions and wait on the corneal procedure. So what are the tools that we have to answer this question? Dr. Ashish mentioned that corneal thickness or pachymetry and various cutoffs have been suggested by different studies. Some suggest 600 or some suggest 640 microns, beyond which you need to do a corneal transplant. I need to point out here that this is not absolute. Indian corneas are in general thinner than Caucasian corneas where these studies have been done. And we have patients with 450 microns or 500 microns or something in between as their usual corneal thickness. So this can be tricky, trying to just keep your central corneal thickness as a cutoff for surgery. Likewise, specular microscopy is useful, but just looking at the counts is not always very clear, because as Dr. Ashish pointed out, in Fuchs, you can have areas with relatively good endothelium and areas where it's not so good, and the reproducibility is poor.
1 minute left.
Okay, so Scheinflag tomography has certain features which can give us clues to these early cases. And there are these definite signs. If all of them are present, it's very, very likely that the patient will need a cataract surgery, and that's what the survival curve indicates. And those patients, you need to do a triple procedure. The third important question is, what are the likely outcomes if we combine the two procedures? So if this question was asked 2 or 3 decades ago, you would say that with a PK, cataract surgery, and intraocular lens placement, at 1 year, about 70% of patients would have 20/40 or better vision. Now, with selective replacement of endothelial tissue, that number goes up to as high as 97% with DSEC and as high as 100% in some cases with DMEC. So you have rapid recovery, excellent long-term survival of the graft, and excellent uncorrected as well as corrected visual acuity. So why would you go for twice the number of surgical procedures, the incumbent risks, anesthesia, and the costs to the patient? Right. So from the patient's perspective, I think a single surgery versus 2 surgeries makes a lot of sense. There's a high degree of predictability and likelihood of long-term graft success with excellent visual acuity. So with appropriate case selection, even in more advanced cases, you can have excellent outcomes with combined endothelial keratoplasty and cataract surgery. And this, I believe, delivers optimal results.
Thank you very much, Dr. Jayesh. That was a very succinct talk. Could you stop sharing your screen?
Yes.
Dr. Namrata, I would want you to summarize this instead of, because each of them have come very clear with their points. Could you summarize it?
I think excellent presentations by both Ashish and Jayesh. And I think even before the debate started, they are very clear, you know, that it's actually not that big a debate, because a lot depends on what can be visualized, what is the endothelial cell status, and what is the corneal thickness. Corneal thickness, like Jayesh very rightly said, is not same. The magic figure of 640 microns may not work for Indian eyes because our corneas tend to be a lot thinner. Specular microscopy, the cutoff is 800, but if you can see everything clearly, Ashish very nicely said that if you can see everything clearly, the corneal thickness is, say, borderline, and the endothelial cells are borderline, go ahead first with the cataract surgery, and then later on see whether you really require endothelial transplant or not. So I think very well covered. If of course it's an advanced case, like the 2 pictures which Jayesh showed, then of course you will go ahead and do a combined surgery right away without actually doing a sequential procedure. But if the visualization is clear, as Ashish said, we would go in for a stage procedure. So I think the debate was, you know, very decisive on its own as to wherein to go for combine and wherein to go for sequential procedures.
Madam, I have a quick question to you. Whenever we look into doing these triple procedure, like the corneal transplant, DMEC or DSEC, along with the cataract surgery, and I'm sure that if they're less severe, you always try to do a cataract if it is more of a harder grade. But when we are doing the specular microscopy, is it just the count which really we take it as a cutoff, or we really look into the quantitative analysis like having pleomorphism or polymegathism or hexagonality of these kind of tissues and then decide, or how do you ideally do that?
As you very rightly pointed out, it's not only about the number of cells that are there, but also the quantification of the hexagonality, coefficient of variation, polymegathism. All these features have to be taken into account before we finally decide the procedure.
Excellent talk by this team and very informative.
One quick question to Namrata. What is the OVD of your choice and irrigating solution?
Irrigating solution would be, of course, BSS plus, and the OVD of choice. If I'm doing only say first cataract surgery, then of course it's going to be Viscot with no financial interest. But if I am doing a combined procedure, I would rather go in for a viscoelastic like Helon, because I know it's going to come out in one blob rather than having to aspirate it for a prolonged period of time.
Thanks.
Thank you. We'll go on to a very wonderful talks by the two of you. We go on to our next team. Our next team has Dr. Arun Jain, a senior leading cataract and refractive surgeon from PGI Chandigarh, who's going to be debating on I prefer Phaco in all my grade 5 hard cataracts. He's going to be valiantly contested by our senior, very popular Dr. Satanshu Mathur from Uttarakhand, who's going to be talking against the motion. Dr. Kamaljeet, I would ask for your thoughts at that time. On to you, Dr. Arun. Could you share your screen? Is he muted? Dr. Arun? Dr. Satanshu is here.
Yes, he's muted and his video is off.
His video?
His video is off and he's also muted. I'm trying.
No, I think we're running short of time. We'll call him next. Mr. Sunil, you should call him. I will go on to the next speakers. I hope it's not problematic for Dr. Suchismita and Shreyesh. Both are there. So,
Yeah.
So,
moving down to the young Turks in the field of ophthalmology, we have Dr. Suchismita, a young cataract cornea surgeon from Pune, who will be talking on the Steven-Johnson syndrome, the chronic phase, whether to keep them on immunosuppressants or not, and should be argued against our dynamic young budding ophthalmologist, Dr. Shreyas Ramamurthy, a consultant and cataract refractive cornea surgeon from the Eye Foundation, a very promising ophthalmologist. So he'll be talking against it. So go ahead, Dr. Suchi, please.
Thank you so much, sir. Thank you, Chitra madam, and entire ARC team for this wonderful opportunity. So I will be debating on a topic where there is not too much of literature available in the role of immunosuppressors in the post-acute phase.
Dr. Suchi, can you please speak loudly or come closer to the microphone?
Not able to hear her.
Dr. Suchi, your voice is low. Can you speak a little louder?
Now can you hear me?
Yeah.
Can you hear me now?
Yes.
Is it okay?
Yes.
Yeah. So I would like to first of all acknowledge so much of literature provided by the pioneering work from our Indian doctors, which has really helped us in managing these challenging cases. However, there is no clear consensus on this particular aspect of using immunosuppressives in the subacute or the chronic phase of SJS. Most of us feel it is an acute single event, and after that, there is a phase where episodic inflammation happens in some patients, but later on they reach a chronic end-stage disease. Of course, in acute phase, though controversial, systemic pulse steroids and even cyclosporin has been used to promote epithelialization and to reduce mortality. And then there comes the subacute phase, and then eventually patient goes into this kind of chronic phase. Not all cases, but up to 35% of patients can have significant ocular changes post SJS. Now, I also agree that at this point, there is no role for immunosuppression. But if we catch this early, when there is ongoing inflammation like this, where there is repeated episodes of subconjunctival inflammation, inflammation at the limbus, inflammation in the deep cornea in the form of deep vessels, infiltrates, melts, in spite of correcting the lid problems, in spite of ensuring lubrication and punctal cautery, there are a subset of patients whom we see obvious clinical inflammation on the slit lamp and even symptomatically. Now, for example, this case has convinced me that immunosuppression probably may be useful. This is an IT professional post-TE and very severe involvement. So she had bouts of corneal inflammation like this with fronts of vessels coming from all directions. This is her right eye on top left over here. And And we had to put her on cyclosporin apart from topical steroids, and we even tried topical tacrolimus. Then it didn't work. We went on to systemic cyclosporin with immunologist support. And in the left lower picture, you can see her after 2.5 years. The corneal luster is maintained. She maintains 6/9 vision, and we see regressed vessels, and she's managing most of her activities. Now, what if immunosuppressives have actually helped her and prevented a more severe disease? This was also a case after lid margin, MMG, everything. She had bouts of corneal melts, which responded somewhat to methotrexate, and eventually it was taken off after 6 months. So is SGS always really a one-time event in the eye? There is a very much variable course in this disease. We all know that. Let us see the literature. These are the few studies I came across where they proved that inflammation is ongoing in these patients after the acute phase as well. And even in cases where there is no obvious clinical inflammation, they found inflammatory cells in the conjunctiva. And even similar to Sjogren's syndrome, they even found salivary gland biopsies having T lymphocytes. So probably there is some ongoing inflammation in a subset of these patients. Rojas et al. Found that in these three red categories, in the lower three ones, that is Stevens-Johnson's recurrent inflammation, Stevens-Johnson's mucous membrane pemphigoid-like variant, and a very rare scleritis-like variant. There are recurrent inflammations very late in the disease, even as late as 2 years. And all these patients benefited from systemic immunosuppression. So in MMP-like findings, they also found that there were antibodies in the basement membrane. Some of these cases even had immunofluorescence positivity. So is the biopsy needed in such cases? I would like to ask panel members eventually. And also cases with ocular surface failure. Of course, the initial event itself causes a lot of damage. But what about the recurrent bouts of inflammation in the limbus causing further damage? So this is again another series where they used some immunosuppressives and they found it to be. Yes, sir. So this is an Indian paper with 5 out of 7 patients where methotrexate, cyclosporin, and azathioprine did help when all other measures like topical lubricants, steroids, and lid margin surgeries failed. So also there was one case, a paper where melts reduced after Kpro in SJS after immunosuppression. The agents used were azathioprine, mycophenolate, methotrexate, and cyclosporin in various papers I came across, and very rarely cyclophosphamide for the MMP variant. So I too believe that for certain subset of cases, if we catch them early, before the burnt out phase, and give them immunosuppressives, of course, very cautiously, along with all other treatments, there may be some role for it. I would like to ask the panel members and off to my opponent regarding this particular issue. Thank you.
Thank you, Suchismita. That was an amazing talk. Dr. Shreyas, can you screen share?
I'll just stop this.
Very nice talk, Dr. Suchi, and it's always a pleasure to be here, and thank you so much, everyone. So I'll just take you all through the management of chronic sequelae of SJS very briefly, and we'll debate why immunosuppression is really not necessary in these patients. Now, let us first understand Stevens-Johnson syndrome itself. Now, while this picture looks horrible and horrendous and is a very acute blistering disease, and the patient is obviously in a great deal of discomfort, you can see that the cornea behind is absolutely clear, pristine, and the luster, even the corneal luster, is maintained. Acute stage itself, the corneal surface itself is not directly involved in the disease. But unfortunately, over a period of time, because of the acute insult, the posterior margin of the gets invaded by the keratinized epithelium from the anterior lid and is replaced and is destroyed. And you have this triad of a dry eye, lid margin keratinization, both of which contribute to having a secondary limbal stem cell deficiency. This causes recurrent epithelial breakdowns. This keratinized surface, as well as the dry eye, causes recurrent epithelial breakdowns, recurrent bouts of inflammation, which can lead to subsequent sterile melts, vascularization, and corneal scarring. Very often, we look at this extensive amount of keratinization, and these are patients where the lids are treated. But very often, the keratinization is not so obvious. It might be very mild and just a migration of the stratified squamous epithelium, which might be quite subtle and might be missed in a number of patients. So it's exceedingly important that we go ahead in this kind of patient who had, you can see extensive vascularization, a lot of corneal scarring, visual acuity of only counting finger 1 meter. And all that was done for this patient was a lid margin mucous membrane graft. If there is one message that you need to take home from this debate or this talk, is that almost the entire subset, except very mild patients of Stevens-Johnson syndrome, almost the entire spectrum of moderate to severe patients of Stevens-Johnson syndrome will have varying degree of lid margin keratinization, and addressing these lids by removing the affected posterior lid margin as well as the tarsal conjunctiva and replacing it with a mucous membrane graft goes a long way in maintaining the corneal surface, the ocular surface of these patients. Now, for paucity of time, I will skip ahead and not show you the entire video. But that same patient with a counting finger 1 meter vision, just an MMG, no further immunosuppression, went on to have a great stabilization of the anterior surface and visual acuity without any other scleral contact lenses improving up to 612. Scleral contact lenses also are an exceedingly important part of management of SJS. They go on to improve vision in these irregular corneas, reduces the contact of the lids with the ocular surface, and works extremely well in combination with mucous membrane graft. Once you've stabilized the surface with mucous membrane graft, you put the patient on scleral contact lenses and give them adequate lubrication. These patients do exceedingly well. There's an excellent paper from L.V. Prasad, which shows in children, because this is really the subset where you're looking at for long term. And over a period of even greater than 8 years in this subset, you can see that there is a progressive decline of vision in patients who have been managed conservatively or with just immunosuppression. But once they have been combined with a mucous membrane graft, and there is a significant improvement, not only an improvement, but stabilization of the vision as well. And when MMG is combined with scleral contact lenses or PROS, which was used there in the study, there was a significant improvement in the vision, which maintained throughout the duration of the follow-up. Of course, you can occasionally do AIOS in patients, especially after a lid mucous membrane graft, once you have stable surface and adequate wetting. This is possibly the only subset which is really going to require systemic immunosuppression to maintain the surface. Again, if it's a dry eye, you can't do it. You'll have to combine it with a minor salivary gland transplant. But these are a subset of patients, when used cautiously, can be useful. Again, in the dermalized surface, these are patients, again, these are stable surfaces. But to rehabilitate them for vision, you need to either do a type 2 K-Pro, OOKP, or a modified type 1 K-Pro as shown in this picture. Again, this is a dry surface, but a very thin pannus. These are patients where you'll have progressive keratinization because of a very dry surface. Even with systemic immunosuppression, this keratinization is going to proceed. And these cases, you can't do, you'd either have to do a type 2 KP or we do a modified LVP keratoprosthesis, as I've done in this patient, where initial mucous membrane graft was done, and then the MMG is raised, the K-Pro is placed in situ, and it is put back again. Now, is there any role? It is an acute idiosyncratic reaction. We have seen even reintroduction of the offending agent. There are a number of my patients after the K-Pro where they have had a sulfur drug allergy which has caused the SJS, but now are being treated with Diamox. There is no recurrence of SJS. There is no relapses or recurrence in other mucocutaneous tissue, whether it is the skin or the oral mucosa. You don't get recurrent episodes of inflammation. What the papers which Dr. Suchi Smita referred to, both Dr. Chodosh's group as well as John Dutt's group, Royas et al., they've all shown increase in acute phase reactants, inflammatory mediators only in the ocular biopsies. There is no concomitant increase in the sera. So when you don't have that, are you over-treating these patients with systemic immunosuppression? Yes, a number of these patients with dry eye, with breakdown of the surface, giving them topical steroids for a duration, they do feel comfortable. But these are again patients, we must remember, it is a combination of dry eye, which is already established, and the rough lid margin, which is causing these breakdowns and causing these recurrent episodes of inflammation. And again, there is no improvement in the extent of dry eye subsequent to starting systemic immunosuppression, as you would normally find in, let's say, in patients of Sjogren syndrome, where once they are well controlled systemically, you find that the dry eye symptoms are also better. So staged and appropriate management is necessary, and you can give promising results even in dismal situations. But systemic immunosuppression, with the extent of side effects that they bring in over the long term, these are patients who are going to live with SJS for their lifetime. And I don't think there is any role for systemic immunomodulators throughout the course of this disease. Thank you so much for your kind attention.
Brilliant. Yes, brilliant.
Brilliant. Excellent talks. And Dr. Namrata,
I think
you ask your question to each of them.
yeah, it's a very difficult subset of patients to treat, and I think both of them have done good justice to their topics. And again, like I said for the earlier debate, holds true for this debate as well. I have had the chance of working with Dr. John Dart in Dr. John Dart's clinic, and the papers were being done at that time when I was working with Suchismita as quoted. So SJS, if you see the initial SJS, as soon as I get the SJS, it's going to be a cornea which is going to be like ours, absolutely clear cornea. But if you keep treating them with lubricants, like, I've seen patients which were being done earlier, they would go into chronicity, or stem cell deficiency, vascularization, conjunctivalization, keratinization, and dermalization, which Shreyas showed. So in the acute stage, it is very important to give immunosuppressive therapy so that that clear cornea doesn't become a white cornea. And like Suchismita said, that you need to give immunosuppressants whenever there's an acute SJS, whenever there are acute exacerbations of SJS. In a chronic SJS, which Shreyas showed, there may be acute exacerbations, again, Suchismita pointed out, and whenever it is associated with scleritis. So when it's a red eye, when it's an inflamed eye, then you may need to give systemic immunosuppression. Of course, in a hot eye, you will immunosuppress, but if it's a white eye and there is no inflammation present, then you don't have to immunosuppress. I would like to acknowledge Dr. Thanarasan here, who's with us. He's been my thesis student. He has published a landmark paper in ophthalmology on the role of acute SJS, AMG versus no AMG, a randomized controlled study. Very difficult study to do because you can only do it, in a place which has a super specialty of dermatology associated like we had. And it was very difficult, and he's done a wonderful work, and it was published in ophthalmology. So, and I'm very proud of Thanarasan, and I'm so happy to see him here. So, in acute cases, you need to do AMG and you need to immunosuppress. But in chronic cases, you need to immunosuppress when there are acute exacerbations and when there is scleritis and when it's a hot eye or an inflamed eye. And I think the step ladder pattern has been very nicely given by John Dart in his publications. But I think a very difficult subset of patients and done very well. I mean, both of them did very well. They very clearly brought out the points. Shreyas showed some very difficult cases of K-Pro, of LVPI K-Pro, of MMGs. These surgeries take a lot of time, and people who are dedicated to do SJS, you will find very few people who want to do it because it takes 2, 3, 4 hours to do these surgeries.
Thank you, madam. I have a quick question to you and Dr. Shreyas and Suchi as well. See, of course, in acute cases, we all know that immunosuppression and steroids works the best. But in chronic cases, when it is silent, few of the authors have prescribed that over the time, the limbal cell failure might happen, even though the eye is quiet. So it leads to the limbal stem cell deficiency, complete failure. And some authors have also picked up in the conjunctivalized cornea, they have picked up the inflammatory cells like CD4 positive, CD8 cells, and also the interferon gamma, which in fact tells us that there is some immune mediated reaction still going on, although there is symptomatically the patient is fine. So how should we judge these patients? You have to do the test for these patients, or when to really stop, or should we keep them on immunosuppressions?
No, so Suchismita was asking this question, should we biopsy these patients to start immunosuppression? I don't think we do biopsy. Biopsy for SJS is only done for diagnostic purposes. It's a case of SJS. But for activity, we normally don't, go and see in for biopsy that way to start acute immunosuppression. We don't do it. We go by the clinical impression of exacerbation, if there's an acute episode present there or not. And stem cell deficiency, Shreyas pointed out ALLOSLET. We've just published a paper, and it's going to be out very soon in the American Journal of Ophthalmology, where we've shown that COMET, if you do, because you cannot take limbus from the fellow eye. And if you do take COMET, that is oral mucosa, if you do, we did it in about 45 eyes, and we've had very good results. So that is something COMET, the cultivated ocular oral mucosal stem cell transplantation, which is another option in these patients.
Thank you very much.
Great points, madam. Just a quick word to
Yes.
what Dr. Srinivas asked. I mean, there is no denying the fact that there are recurrent episodes of inflammation after the acute phase. But the question is, what is the source of that inflammation? Why is there inflammation? The inflammation, what the cells which we see, is secondary to breakdowns of the ocular surface. Why is the breakdown happening? It's a combination of the lid margin keratinization and a combination of dry eye. So obviously, once we have a breakdown of the surface, there is recruitment of inflammatory cells. But are these patients, do we have to systemically immunosuppress them? Or will just systemic immunosuppression help them? Definitely not. The idea is to say that we treat the lids, treat the surface, I mean, with scleral contact lenses, lid mucosal grafts, as well as minor salivary gland transplants. But systemic immunosuppression can be avoided for a very, very small subset where, despite all these measures and all these being stable and good lid mucous membrane grafts, if that very small subset, which if at all there is a recurrent inflammation, maybe would benefit from a short period of systemic immunosuppression, but definitely not in the long term.
They might go in for the dry eyes as well, because we have seen few patients, they go in for dry eyes.
Dry eye is already there, where after following the ocular surface damage from the acute episode itself, there is a great damage of the goblet cells and damage of the ocular surface, which happens during the acute episode. But it is the lid keratinization which chronically rubs on the epithelium, causes recurrent breakdowns, and also damages the limbus subsequently, which causes a secondary limbal stem cell deficiency, which you don't necessarily see primarily during the acute attack. Like madam mentioned, once the acute attack is very well managed, which it is very often in these foreign countries like Dr. Dart's group, as well as in Mass Eye and Ear, once it is very well managed, they don't see lids or this thing which is as bad as what we see in our country. They're all much better, and these are patients with just with just lubricants and minimal immunosuppression are able to carry on for a long period of time.
Thank you very much, Shreyas
nice.
and Suchita. I think we'll have to go faster because 5:30 we have to wind up, Srinivas.
Yes,
so,
ma'am.
So we have to ask fewer questions. The next team is Dr. Santosh Bide, a senior cataract surgeon from Pune, who is going to be talking and who has won who is going to be talking on why I prefer iris hooks for all poorly dilating pupils. And he would be contested by our eminent and senior ophthalmologist from Mumbai, Dr. V.C. Mehta, who would talk on why he would prefer rings. On to you, Dr. Santosh.
Yeah. Am I audible?
Yes.
Yes, sir.
And my slides are visible?
Yes. Your video.
Oh, but I am not able to go back.
You're playing the video?
So just stop share for a minute.
Stop sharing.
Then
Yes.
share again.
And on your presentation, just go to the first slide, sir. Then start share.
Till then, can Dr. V.C. Mehta start? Hello.
Yes.
BC sir.
Yes, I'm ready. I'm ready.
Yeah.
But my video is stopped by you guys. So can they start the video?
You have shared the video, sir?
Yeah, but my screen is not being shared.
Hi. Mr. Sunil,
The host is asked to start your video, please.
Dr. Mehta.
Yeah.
Can you just click now? Yeah.
Yeah. Okay.
Yes.
Right now, every phaco surgeon is faced with the prospect of operating in a non.
So you need to share. You need to start sharing.
Okay. Share the screen. Is it visible now?
No.
No, sir. Yeah.
Yes.
Okay. Okay. Every phaco surgeon, as you all know, need to operate on a small pupil which does not dilate with our medications for various reasons. And in all these cases, my first step is to insert the ring. And I use Malyugin ring, but there are many rings available now. a little bit of viscoelastic below the iris helps a lot in engaging the loops into the pupillary border, and those which do not get engaged can always be put in place by a side Portsinski hook. In cases where you have a fibrotic membrane because of the recurrent iridocyclitis, as in this particular case, I don't stretch the pupil. I let the Malugin ring or any other ring to do that job. Here you can see the flexibility of the ring, which is nothing but a 5,0 polypropylene. And you can easily kind of bend the ring so much that you can put it wherever even in a very small kind of an iris. Now, in this particular case, again, a case of chronic iridocyclitis and attacks of recurrent high IOP. The whole ring was released in the anterior chamber, and one by one, we could put all the loops and engage them into the pupillary border. And it gives you a wonderfully circular pupil. It maintains the anatomy of the iris. That means the anatomy is not shifted like in an iris hooks. The only thing is when you are handling this kind of situation, you need to be careful that you don't puncture the anterior capsule. Now, very rarely in a very small pupil like this, instead of putting straight away the ring, I'm going to expand a little bit whatever pupil enlargement happens, and then again try to put the rings. So all in all, even in a very small pupil, the pupil can be expanded with a pupil expander to give you a wonderful exposure and help you to do a case without any problem. Now, you may start the case with a good pupil, but you get into a situation where the iris starts misbehaving actually, and shows the first sign of floppy iris. So I don't proceed at all, and midway I inject the ring, again taking care that you inject viscoelastic below the iris so that the anterior capsule is not picked up by the ring. And very rarely it has happened that one of the loop has also taken the anterior capsule, but it really doesn't matter. It never tears the anterior capsule. And you can see this another case. Again, you put in a viscoelastic under the iris, put the ring very easily, and proceed with your case without creating any problem. Once I had this loop going behind the iris. Now you don't chase the loop at all, but you pull the other loop, and the rod comes out, and you can then put it into the correct place. Removal of the ring is equally important. You engage the proximal loop, and then with the second instrument, both the loops should go into the cartridge. If that doesn't happen and you try to pull out without being careful that each loop is there, it gets stuck at various places. The eye, as you saw, iris border, and then the wound as well. And in this particular case, there is a lot of hypotonia. I haven't injected enough of viscoelastic, and therefore I'm finding it very, very troublesome to pull the rings out. Please don't do this. Inject enough amount of viscoelastic.
1 minute left.
Yeah, so that the ring gets into the mid anterior chamber. Now here, one of the edge of the ring is not into the cartridge, and even then I retract it. There's one sweep which has happened, and I thought I will get it into the cartridge, but then the second sweep happens, and if you can see properly, in the second sweep, the large iridotomy which was done in a glaucoma surgery, the loop gets entangled. And this was the only occasion where I had to literally cut the ring and then take out the loop with the help of forces. There you can see disentangling from the large iridectomy. In today's time, in India, a lot of our colleagues have come out with the rings like the Gupta ring or Suben Bhattacharya's ring, and they are quite competitively priced. And so in today's time, there is no need for you to use any of these loops. The iris hooks. They are meant for the for the capsule and not for the iris. And for me, any small pupil expander is the way to go. Thank you very much.
Thank you very much, Dr. Mehta. Lot of information from your videos. Could
Thank
we
you.
have Dr. Santosh?
Yes, please. Yeah, I'm ready.
You will have to stop.
Yes, I started sharing. Okay, am I audible?
Yes, yes.
So at the outset, I would like to thank Dr. Chitra Ramamurthy and team ARC for giving me opportunity. So my talk is on why I would prefer iris hooks. I do not have any financial disclosure in any of the products. In day-to-day practice, we come across small pupil and dense cataract, and we all know that there are different causes, and commonest being old patient with diabetes and pseudo-exfoliation and floppy iris. And we all know that there are multiple challenges because of small pupil, because of reduced space, the capsular axis becomes small, which in turn cause difficulty in nucleus management, leading to iris trauma, posterior capsular rupture, retained cortex, difficulty in placement of IOL, risk of endothelial damage, and poor outcome. So we have to actually plan the strategy for managing small pupil. We have to use proper mydriatics. Choice of viscoelastic has to be proper. And we can always use Phenocane Plus, which is a very good medicine which we can use intracamerally. And there are different pupillary expansion devices which we can use. We all know that there are multiple devices. And Dr. V.C. Mehta has shown excellent surgeries, but he has also shown certain complications which take place while using a Malugian ring. So choice of device basically depends on the critical diameter of the pupil, the experience of the surgeon, intraoperative situation, and different properties of the iris. So actually, while using iris hooks, we have to take a posterior incision. It's only 0.9 millimeter, and the direction has to be towards the lens. It should not be parallel to the iris so that there is no tenting of the iris. We do achieve sufficient dilatation of the pupil, and then all the steps are very easy because the pupil is sufficiently dilated, and we can proceed with Phaco emulsification in a quite easy manner. Here is the next case where there are dense posterior synechia, and we have to usually stain anterior capsule before. We have to remove pupillary membrane. That is a very important step. And then use of iris hooks is very easy. You can adequately dilate. You can in fact titrate the dilatation of the pupil. And then all the case is extremely easy. And removal of iris hooks is also extremely easy as compared to the Malugian ring or any other pupillary expansion devices. So ultimate aim of our surgery is to give good results to the patient. There are some prerequisites while using pupillary expansion devices, like we have to choose viscoelastic device properly. One has to avoid overfilling of the visco in the anterior chamber, because then the iris goes back and touches the lens and it's difficult to use iris hooks. Pupillary membrane has to be removed, posterior synechia has to be removed. And my reason for using iris hooks is that it's very easy to use. There is hardly any learning curve. It's cost effective. It can be used in all types of small pupils. If there is a shallow anterior chamber, then also we can use very easily, because shallow anterior chamber can be a challenging situation to use Malugian ring or other devices. And another important thing is it does not interfere during intraocular manipulations. So I prefer iris hooks over other devices. Thank you again.
Thank you, Dr. Santosh. That was a wonderful discussion which you, opposition you gave to Dr. Mehta. I have a question for you. When you're using iris hooks, can you, general information, what measure would you take to avoid a larger sphincter tear in the pupil?
Actually, while pulling the iris hook, you can titrate so that you need not pull at the first go. In fact, if you are using suppose 4 or 5 iris hooks, just introduce all the iris hooks and then pull one at a time gently so that you don't tear. Of course, it is known that it does cause slight distortion of pupil post-operatively, but actually the operative safety is more important rather than micro tears of the sphincters.
No, you should avoid too much of traction for too long a time with iris hooks.
Yes. Yes.
Avoid.
Can I ask?
Yeah.
Yes.
Can I ask a question to both the speakers?
Yes.
Sir, Dr. V.C. Mehta, sir, and Dr. Santosh, if a patient were to choose a multifocal IOL and other than a small pupil, all other parameters are okay, would you advise a patient a multifocal IOL? Which pupillary expanding device would you use? And would you advise a flax for this patient? Would you recommend a flax procedure?
Shall I answer first?
Yes.
Okay, and as in a small pupil is not an absolute contraindication for a multifocal IOL. And you have seen, I always use the Malyugin ring for a pupil expander as a pupil expander. The main reason is that the pupil is not distorted post-operatively, and in fact, you leave a pupil slightly larger than what you started with pre-operatively. So that, I mean, I don't want to do put in a pupil expander first, then take them for the LenSx and then bring them again to the OT. So I flatly refuse doing flex in a small pupil.
I think BX is a good alternative.
BX,
absolutely.
But for rigid pupil, it is really difficult to achieve proper dilatation.
I will not do flax for these patients, but BX is a good because it doesn't distort the pupil.
Doesn't distort at all. Very, very soft.
The main problem with Malyugin, in my hands at least, is just removal of the Malyugin is more a problem than putting it inside. So
some very difficult cases.
So the video, sorry.
I showed some very difficult cases, Dr. Mehta, but in a small pupil with IFS, what would be the challenge in placing the Malyugin ring? See, you are out of the debate. You can be reasonable now.
Well, IFS is the most important indication for using a Malyugin ring. There are cases which you miss preoperatively and you don't suspect an IFS, as I've shown you 2 videos. And the first indication of IFS is when you do the hydro. When you do a hydro procedure, the pupil suddenly goes down and the iris starts coming from the side port. I would strongly suggest do not proceed. Do not proceed with the case. Put in unless you put in a pupil expander in place. Once the pupil expander is in place, and especially with the Malyugin ring, the billowing of the iris is also kind of prevented. So I don't know. I don't have an experience with the other rings, Indian rings like Suven and Gupta, but with the Malyugin ring, definitely the billowing is definitely much less. So
the video that
sorry. Yeah, sure. Go ahead, please.
So the video that you showed where the Malyugin ring, one of the hooks was actually pulling on the iris edge. Yes. So what I have found is when I actually manually first detach the hooks and then remove it, then it doesn't pull.
Yeah.
So what the
video?
Out,
no, the video that I showed was to tell that you should see that both the side rings actually go into the cartridge.
Right.
So you have to have that side port guiding the rings inside the cartridge. The first one goes, and at that time you have to see that both these arms of the rings are above the cartridge, and then both the rings they go inside the cartridge.
Excellent presentation.
Dr. Srinivas, can you introduce the next team, because I think we won't have time for all of them to talk. Wonderful discussions.
Thank you.
You have to move on.
Good to see you, Rama.
I'm not getting a chance to speak with.
I know you.
Neither at home nor here, sir.
Catch up with you later on, Ramu.
Okay, so let's go on to the next set of speaker. Interesting topic on pseudophakic diabetic macular edema is going for is Dr. Preetham Samant, our very close senior colleague in the field of vitreoretina and very well known. Is from JJ, and he'll be speaking on the pseudophakic diabetic macular edema. And the first choice is intravitreal steroids. and you'd be argued against by Dr. Thenasaran, another young and dynamic surgeon from the Eye Foundation, as his first choice as anti-VEGF. Over to Dr. Samant sir, please. Preetham sir.
Thank you, Dr. Srinivas. At the outset, my gratitude to Dr. Chitra madam and the ARC for having me here. It's a phenomenal feeling to be in the midst of all the doyens of Indian ophthalmology. So let me kick off the talk. I'm up against a very formidable opponent. I believe Dr. Thinarusun, and Dr. Namrata Sharma just threw a googly sometime back. She said that he's a student and he's a wonderful student. So I'm wondering what he's doing with the retina topic. So when I heard that, I've prepared a googly at the end of this presentation for him. So let me start the presentation now. So pseudophakic DME. So when I debate this topic, I have to debate why I will go for steroids in pseudophakic DME, diabetic macular edema. And then the second part of my presentation is why I will not choose anti-VEGFs. So what are the treatment modalities we have for diabetic macular edema? Laser is not so popular now because of the collateral damage we know. So that's why we are left with the pharmacotherapy, that is anti-VEGFs and steroids. If there is DME with traction, we go for surgery. Now, corticosteroids, there's ample evidence in literature that corticosteroids are broad-spectrum anti-inflammatory agents that affect gene transcription and protein upregulation, and they do play a role in diabetic macular edema. In fact, they don't only have anti-inflammatory effect, but the effect also crosses over and has some anti-VEGF effect on the diabetic macular edema also. So essentially, they help to bring down the inflammation. They work on angiogenesis, reduce the oxidative stress, help with the apoptosis and neuroprotection. Now, this is a picture from more than 10 years back when we had only triamcinolone, and you can see how well the triamcinolone has helped in controlling the diabetic macular edema. A repeat triamcinolone again helps to this 3 months post triamcinolone. The diabetic edema does come back, and you have to repeat it, but after almost 3 months. So when I debate on why steroids, I will tell you why they are, the efficacy of the steroids and the safety profile, because these two things are important when you root for one particular pharmacotherapy. And what better way to talk about the efficacy than this landmark trial, the DRCR network trial, which was one of the major guiding principles for treating diabetic macular edema. This was a trial which had a head-to-head comparison between anti-VEGF and triamcinolone versus sham treatment. Now, what they found was in the first year, you can see all of them going hand in hand, all of them going pretty well. This is the steroid and these are the two anti-VEGF arms. They are going pretty well. But when you saw towards the end of the first year, the steroid arm started dipping down. The results started going down, whereas the anti-VEGFs, the vision improvement was much better. Now, mind you, this was the entire subset of patients. When you look at only the pseudophakic patients, that is this results is only in pseudophakic DME. When it was extrapolated in pseudophakic DME, you can see the steroid arm doing in fact better than one of the anti-VEGF arms and equally good as the both anti-VEGF arms. So I think we have enough evidence to say that the efficacy of steroid is there. What about the safety profile of steroid? Now, if it's a patient with systemic comorbidities, I will feel very safe to give an intravitreal steroid. If it's a pseudophakic patient, anyways, I don't have to worry about cataract. My only concern would be glaucoma. But then, triamcinolone is history now. We have, fantastic armamentarium with us like this dexamethasone implant, which gives a metered dose of dexamethasone over a sustained period of time. So it is not only safe, but long acting. In fact, there are certain randomized trials, recent ones like this MEET trial of 1,000 patients, where you can see how minimally the IOP goes up. This is the baseline sham treatment, and with the dexamethasone implant in DME, the IOP is going up and coming down again. So really speaking, glaucoma is a concern, but not as much as it is made out to be. So what is the advantage here? It is long acting. More importantly, lesser visits for the patient. Remember, your diabetic patient is not only visiting you, he is going to the nephrologist, he is going to the endocrinologist, he is going to the diabetic food guy. So he has to visit so many people, and if he has to come to you every month, he's had it. More importantly, less cost. So look at your elite and the poor patient. In the elite patient, where you're going to choose Ozurdex over these two, still your cost is less. In the poor patient, your triamcinolone, which is 70-80 rupees, is still lesser than the aliquot of bevacizumab that you're going to use. So it is a winner definitely all the way. This is one of my recent patients. You can see the diabetic macular edema, the FFA, the OCT, and with 2 implants over a period of 9 months and some rescue laser, you can see how the diabetic macular edema has come under control. Now the last part, why will I not prefer anti-VEGFs in some of these cases is again repeated dosing. So repeated visits, uncontrolled diabetics bind you multiple infections, multiple chance of infection and endophthalmitis. That also has to be taken into account. The cost factor is large, and diabetics, there is always insurance woes. The insurance company is always saying no to diabetics. Mind you, take that into account. And if there are comorbidities like ischemic heart disease, cerebrovascular comorbidities, then you have to bear caution with anti-VEGFs. Remember, one of the major trials, that is Protocol T, although they did not find a significant adverse events in some of these anti-VEGFs, if you look at the fine print, a greater number of non-fatal strokes and vascular deaths did occur in the ranibizumab group, although not statistically significant. And there is enough evidence in literature where they have studied pharmacokinetics and shown that these anti-VEGFs actually reduce the normal plasma-free VEGF levels. So that can cause a higher chance of a cerebrovascular accident. So this is my concluding slide, that when you're making decision in pseudophakic DME, in any DME, you have to take the lens status into account. If it's a pseudophakic patient, then I will definitely go towards steroids. But look at my algorithm. If it is a focal non-center DME, then laser will still be the gold standard. If it is a diffuse center involving DME in a phakic patient, I would probably go towards anti-VEGF. But if it's a pseudophakic patient and who's not a steroid responder, I'm not worried about glaucoma, I will choose steroid. Now for the googly. Now what happens if we combine steroid with anti-VEGF? So this is a question for my dear opponent when he talks. Thank you again.
Thank you, Preetham sir. You made your points very well. And now we'll go ahead with Dr. Thenasaran, please.
Yeah.
Yeah,
My screen is visible?
No.
Not yet.
Yes. Good evening, everyone. And I'd like to thank Dr. Chitra ma'am and AIOS for giving me this wonderful opportunity. So I'll be debating about why anti-VEGF should be the first choice in pseudophakic DME. So for that, we should understand the pathogenesis of diabetic macular edema. So the best agent of choice should act against both the mechanism. It should also have anti-VEGF effect and it also have anti-inflammatory effect. So as Dr. Preetham has mentioned that steroids do have both the effects. Similarly, anti-VEGF agents also has both anti-VEGF and anti-inflammatory properties. So we have a wide range of anti-VEGF agents. So ranibizumab and aflibercept. Ranibizumab being an antibody fragment has a smaller size, has deeper penetration and faster clearance, both from the vitreous and as well as from the systemic circulation. So it primarily indicates the less systemic side effects compared to the larger molecule bevacizumab. And again, aflibercept has a wide range of action against all VEGF and placental growth factors. So this study shows that anti-VEGF inhibits the leukocyte transmigration and leukocyte re-entry into the cells of retinal circulation, especially in the angiogenic retina. So it indicates that in addition to the anti-VEGF property, so these agents also have anti-inflammatory properties. So coming to the DRCR NET and RESTORE study, so they have indicated that especially in the protocol I, so if you start early treatment with ranibizumab, it provides sustained visual acuity gain over a period of time. So it has been studied in the RESTORE study as well. So if you see the protocol, as I saw, Sarah's mentioned clearly, but if you see the subgroup of pseudophakic and phakic patients, pseudophakic patients have an equal compared to the anti-VEGF and steroid. But if you see, compare the side effects, the systemic and local adverse effect, that is the IOP rise, the ranibizumab group has less side effects. So I would prefer going anti-VEGF as a first choice compared to steroid therapy. The recent protocol U, they have two groups. One is the monotherapy anti-VEGF and second is a combination therapy anti-VEGF along with a dexamethasone implant. At the end of 6 months, if you see, there is no any statistical significance between the two groups in compared to the final visual acuity. But if you see, the IOP rise is more with the combination group. So why would you prefer a combination group if the visual acuity, there is no any difference? So you always prefer anti-VEGF as a first choice. So in nutshell, if you see this tabular column, so all these studies at the time of a final assessment at the end of 3 years, the final visual acuity is more or less same, or in the case of VEGF, it is slightly more compared to the implant, dexamethasone implant. So again, if you compare the side effect profile, so I would always prefer anti-VEGF as a first choice. In the MEET study, the dexamethasone implant, the increased IOP was the second most adverse effect, and it is seen in almost 30% of cases. So if you see, after intravitreal steroids, the IOP rise, the risk factor increases after a single injection. But whereas if you compare with the anti-VEGF injection, the risk factor increases if it is more than 12 injections. And again, the percentage is very less compared to the steroid group. So the increased IOP is a common complication of intravitreal corticosteroid, regardless of method of delivery. So again, this adds burden to the patient for treatment for managing glaucoma, and again the patient needs additional follow-up and for the frequent monitoring of IOP. But Sarah's mentioned that if you give an intravitreal steroid implant, you can follow up the patient once in 2 or 3 months, but it's not so. If you want to monitor the IOP, if you wanted to monitor the close monitoring of IOP, you need a patient for frequent follow-ups. So again, there is an anterior chamber migration of intravitreal implants and IVTA. So this can again damage corneal endothelium, and this risk factor is more in cases of pseudophakia and if there is absence of lens capsule. And there is some entity called sterile endophthalmitis. It is a non-infectious. It is mainly due to the toxins and preservatives in the syringes, and risk factor incidence is more in intravitreal triamcinolone compared to the anti-VEGF agents. So again, if a steroid responder is there, definitely you cannot choose a steroid. The anti-VEGF should be the first choice. Again, if there is a tachyphylaxis to the anti-VEGF, again, you can change to a different drug, and again, anti-VEGF should be the choice. So in conclusion, so the benefit and risk ratio of treatment should be considered in patients with diabetic macular edema, and evidence-based medicine is very important. So my first choice should be anti-VEGF as a monotherapy in cases of diabetic macular edema. So if the patient is not responding, and if there is a chronic edema and is refractory to therapy of anti-VEGF, then you can go in for a combination therapy of anti-VEGF along with steroids. Thank you.
Thank you very much, Dr. Tennerson. Wonderful talk. Preetham and Tennerson both were very good. Srinivas, you can ask one question and we have to go to the next.
I think Preetham and Dr. Tennerson, nowadays we are, I think Preetham sir will agree with me, we are looking more for the OCT biomarkers nowadays, like the presence of the hard exudates, hyperreflective foci, the tall cystoid spaces, and especially the cystoid spaces in the outer nuclear layer, association of drill. I think they are now guiding forces whether to go in for the anti-VEGF or go in for the steroids in these kind of patients. And DRCR protocol that you showed is the IVTA. Nowadays, I don't think many of us are actually prompting for IVTA because dexamethasone is showing result. It is cost effective, as Dr. Preetham said, because if you take 3 anti-VEGFs, even if you take a ranibizumab, bevacizumab, even if the least choice is 8,000 rupees, if you convert 3 months, it becomes 24,000 rupees. Ozurdex, I think, is fairly charged somewhere between 25 to 30,000 rupees.
Yeah,
so I think I will, yes, sir?
See what has happened to the patient.
Yeah. Yeah, that's what. See, basically in chronic cases, I think steroid still has the main role. In earlier cases, I think anti-VEGF can be given if none of these OCT biomarkers are present. I think the present world is going towards there rather than comparing the much of the studies which are now actually not relevant because the dexamethasone is now changing the game plan.
Yeah.
Okay. Thank you very much.
Very nice.
Paucity of time. We need to go on. Excellent discussions. Is Parul there?
Parul's not there. I'll start first. She'll join in.
Okay. After that, Dr. Satanshu, I think we are not able to locate Dr. Arun Jain. We are going to hear your debate alone without him. Okay. So this is the second last.
I can speak for Phaco or SICS if you want in between. I'll give some finer points.
Yes, Dr. Kamaljeet, I would want your thoughts.
Absolutely.
When Satanshu talk. Yes, 100%. I'm glad you joined. Second last team is led by Dr. Parul Sharma, who's an eminent cataract refractive surgeon from Delhi, who's going to talk on high-end phaco machines is a necessity. And she's going to be contested by our ever-energetic cataract cornea surgeon from Mumbai, Dr. Jenin, who's going to tell us that technique is more important than technology. So we are going to have Jenin talking first, and then she'll be followed by Parul.
Is my screen seen?
Yes.
Okay.
You're
okay. Okay, good evening, everybody. So we've all been extremely lucky to be in this era where technology has boomed, and because of which we've all seen the added advantages in our life. So for most purposes, a man with a machine is better than a man without a machine. I'm not able to change the slide.
Go to the bottom left. The arrow is there.
Okay. So the question is it technique or technology in cataract surgery? So looking at this case where I'm just showing the part of nucleus fragmentation, because that's where the art and science of technology and technique match. So it is important that our technique is of a direct chop. So learning all the different techniques that are necessary is important. Also, it is very important because we want to decrease the energy amount that is used in the phacoemulsification. You want to do the chop in such a way that there is a clear purchase on the posterior pole in a hard brown cataract like this. Then central area, the central zone or the nuclear is emulsified first, and then smaller fragments are made such that depending upon the grade of the cataract, such that your emulsification is faster. You can use OVDs, which are now very much better for protection of your corneal endothelium. Especially when you're using the lower end machines, you have power modulations, hyperpulse mode, and the pulse mode and micropulse mode. Vis-a-vis the case like this, which is again a hard brown cataract, where the chopping technique is not very good and there is not a complete purchase over the posterior pole. In such a case, what happens is when you haven't done your technique of chopping well, even if you have an higher end machine, you may tend to have complications in such a case. So definitely your skill sets of surgery is very important. And this is the rent. So then you go ahead and manage the rent that is there. So having an eye-hand phaco machine does not mean that you're never going to get complications at that machine. What's very important is learning to handle the complications such that you have results like a normal phaco. Now looking at this case again, which is a hard brown cataract, you could go ahead and use micropulse, burst mode, and again hyperpulse mode for the phacoemulsification. Use a good OVD, but you have no hold if sometimes you may tend to get a surge, which may happen, a complication may happen. What is important is managing the complication well, such that you give the patient a good vision. Now, when you have a situation like that, where you have a complication, you have to start thinking, what's your next move? Not get anxious, breathe. Like in a case like this, you've already got a rent. Instead of the machine is now of no use, you do not want the chamber to fluctuate. So you put an OVD, you secure the nuclear material on one side, you do a tricot assisted vitrectomy. At this stage, I know that my rent size is small. I do not want to increase the size of my rent. What I'm going to do is I'm going to shift my mode to a pars plana vitrectomy. By doing a pars plana vitrectomy, I'm pulling the vitreous back into the cavity. I'm also going to make sure that at no point there's going to be fluctuation in my anterior chamber. So I'm going to put an OVD, not allow fluctuation to happen for the rent size to increase. Now, once I have done this, I have made sure that my rent has not increased. I keep my nuclear material safe. I use the technique of an IOL scaffold. And since I have a good bag, I can put the IOL into the bag, dial the IOL in place, then go ahead and have the nuclear materials emulsified. The advantage of this would be that you prevent the nucleus drop from happening. You're not causing any fluctuations. Your machine is not playing much of a role in this case. And you can have the post-op results, which are like this. So this is extremely good results and the patient has near normal vision. Now in a case like this, which is a case where you have already finished your emulsification, you may tend to have a PC tear like that, which is an inadvertent tear. Your surgical technical skills of converting this tear into a PCC is extremely important so that you can have an in the bag IOL implantation. Also, what is important is learning to convert this into the test. So no machine can now do this for you. So you have to have your surgical skill sets. Now, sometimes even when you're doing this, you may also have a situation where unfortunately your trailing haptic breaks here. You need to now remove the lens without causing fluctuations in the anterior chamber, without causing the vitreous to prolapse, using a good OVD and having your surgical technique in place. Many a times, even when you put another lens into the place, it is important that you use your iris hook here to retract the iris so that you can see the edge of the capsular bag and dial the IOL in place. So just because I want to conclude my talk, so it is very important that no machine can control the skills, but good skills can definitely control any machine. Who is the big bull that we are looking at? We need to have a respectable balance. They form a solution where one pushes the other. What's important is to have your skills right. Technique definitely matters, and definitely the man behind the machine matters. Thank you.
Fantastic, Janin. You didn't, it doesn't matter if Parul has not come.
Parul
has she come?
Can you hear me? I'm at the airport. I've just landed. I don't know how audible I am, and I yet have to collect my baggage. So I don't know if I'm going to get my suitcase. So let me just quickly get into the debate right away.
Yes.
Can you hear me?
Yes.
Okay.
Welcome.
Thank you. Where do I go for sharing?
It's on the screen bottom.
So I'm sharing. If I say share screen.
Yes, it will share your full screen.
Since you're in the airport, you can just check in the counter.
No. Don't disturb her now.
What is it doing? It's saying desktop only. And in desktop, I can only see you.
You have not started screen sharing as of now, Doctor.
Share screen.
Dr. Parul, first you have to click the screen share, then you have to share. The next step is to select what you want to share
and then share.
Open the PowerPoint and keep it.
Yes, you're open. Yes. Great. Fantastic.
Sorry about this. Okay. So I'm going to use a bit of this slide only because some of my surgical videos were not coming up when I checked. So the whole debate is about whether it's actually necessary to invest in the high-end machines that the company sell us. Do we really need them, or is it just a fad? So when we talk about any kind of innovation, we know how we started our OTs from peristaltic machines, and we came on to the dual machines, and now we are at the end spectrum, and God knows what after this with the femto laser. So the debate here is that we start from cataract is no more restorative. We know that it's refractive. The profile of our patients has changed. The demand of our patients have changed. So the equipment which we give them when we want to give them results, it becomes very important. So let's just talk about facts. And as Dr. Janin rightly pointed out, of course, you need a good driver to drive the car. But if your car is not good enough, then here we are not taking any chances because it changes people's lives. So all those words which Dr. Janin had beautifully used, and she's a great surgeon and has great technique, but those may, we may get a surge, we may have a rent, we may have this. So the investing in the high-end machine takes control of that may part. Not only this, apart from what you're seeing on the screen, the higher-end machines give you, it also saves you a lot of ectopics, and it's resulting in a longer life for a surgeon. So today's phaco emulsification incorporates advanced technology, has very clever design elements, and that makes the cataract surgery safer, faster, and less taxing for the surgeon. So I'll just share like what we use in our OT now is the Centurion machine, for example. It uses the active fluidic system, and it's designed to maintain the target pressure inside the eye. And it does it by having a variable rather than a static input. So the bag of fluid is inserted in the machine. It has pressure sensors, it has plates. It's able to change the pressure in the bag very rapidly in response to any kind of feedback from the sensors and maintain that rock stable anterior chamber. So apart from the two advantages is also the fluorated tubings which have been modified, the two pumps which are configured, which cancels out those small pulsation that a peristaltic pump in our older machine used to produce. You know, those small pulsations have traditionally been the downside of the peristaltic pump technology. And the rotatory valves in this, so any kind of active fluidic now has sensors. So before the optical break happens, before the surge happens, the machine will put in some extra fluid there to maintain your chamber, and it makes your life very, very, very comfortable. So it's so adaptive and adjustable with the whole automated procedure. So it could be like the white star technology, where they have something on this fusion fluidics, where they have incorporated both the peristaltic technology to give you great holdability and intraoperative control, and also gives you a venturi system which has great followability. So you're not running after segments. So, in these kind of cases, when you are grade 5, these machines give you the power to use minimum energy, so you're Phaco efficient, and you're using them with maximum confidence. So, for example, if I show you here, if you see the holding, and it's a grade 5 cataract, the chamber is rock solid throughout. And people who we need to know. Stability in a hard cataract. So similarly here, if you see, we are very wary of patients with optic nerve compromise in glaucoma and ischemia. So in machines like this, we can actually do the whole of cataract surgery with low IOP at almost 20 maintained throughout. So if you see in this particular video, we have finished a whole grade 3 to 4 surgery with the IOP maintained, which is not gravity controlled, and the sensor sends how much fluid to give in, and hence I can do the whole surgery at an IOP of 20, which is a great thing for patients with compromised optic nerve. Similarly, what high-end machines do when we need them most is the vitrectomy. It is smaller gauge. It has got higher cut rates than our previous machine. So here is a subluxated case where I already had a vitreous before I started the case. So the machine gives me the privilege of doing a beautiful vitrectomy before I start, and henceforth just carry on with my case easily, where I can use the capsular hook and wand. No question that technique is needed, but machines do make your life comfortable. So if I go back to why should we invest in the technology, we know all about this, that we want uniform performance every time, and time saved is money earned in high volume OT. So hence we need those higher end machines. And if you know how to drive, I mean, it's very, very obvious what you will want to choose. Would you want to choose this, or would you want to choose this? So the only problem is, if you want a high-end car or a high-end machine, where does the money come from, right? Now, is cost really an issue? In current scenario, we have bank loans, we have deferred payments, we have leases, we have rental sharing. So I don't think this is really a reason for us not to invest in high-end machines. And every single surgeon of ours here has upgraded. And to know your enemy, to know my friend, Dr. Jenin is a good friend. And I know that she has upgraded from Infinity to Centurion. So I rest my case here. Even my opponent has went ahead and invested in a high-end Phaco machine. So I would just like to conclude that, use the best of both the opportunities. And thank you so much. And I have to rush and collect my bag now.
You did a wonderful job. Both of you spoke very well. And I know both of you were traveling. It doesn't matter. We're not going to ask your questions. Your part of the debate is done. We shall now go on to Dr. Satanshu Mathur, who is going to tell us, without his other debater, that why he would prefer SICS only in a grade 5 cataract. Dr. Satanshu?
Yeah, thank you, Chitra. Thank you, Srinivas. Thank you, AIOS.
I think the opponent knew that you will win, so he ran away.
So my opponent has run without the debate. That's the importance of SICS in hard cataract.
Yeah.
So why SICS in hard cataract? If you're sitting like my friend Arun Jain in the PGI, having high-end machine, and you are having the retina setup backup for Phaco drop, you have cornea setup for endothelial damage, that is okay. You have high-end machine. But what about the general ophthalmologist who is not at par with all these facilities? So SICS is the operation of choice. There are different types of incision you can give. State incision is good for the newcomer, and this is the incision what caused minimum estimate in chevron incision. And nowadays we are giving inverted batwing incision, where we give 4 mm incision 2 mm away from the limbus and extension on the both sides vertically. And this gives minimum estimate around 0.5 to 0.75. So incision you can verify according to your experience, but rexis in most cases is 6 mm. It is successfully requiring all the cases. This is the case where intentionally I have given 6 mm incision. Why? This incision is preoperative estimated in patient was 1.5 diopter at the level of 100 degree. So by giving this incision at 100, keeping the 100 degree at the center, 2 meters away from the limbus, I have covered 1.25 diopter estimated postoperatively. And patient has residual astigmatism of 0.25 only after surgery. In Phaco, you cannot correct the preoperative astigmatism without the use of toric lens. This is the beauty of SICS. We are correcting the preoperative astigmatism also. The importance is the incision, and then rest of surgery is same as we are doing all the cases. Made side port, dye injection. In this case, is important is the side port in the side pockets. Side pockets are very important because external incision is small, but by making side pockets, we can take out the hardest nucleus from the incision. Rexis is done quite comparatively large than Phaco for the easy removal of the nucleus in the hard case catheter, what we are discussing now. After doing Rexis, inject the, now we are enlarging the incision. You see, we are making side pockets. This is around 8.5 mm on both the sides. So important side pockets that whenever the nucleus engage in the side pocket, we can break it in the tunnel area and can remove the nucleus by small incision. In this case, we have made the incision larger to control the preoperative astigmatism. Otherwise, we remove the hard nucleus by only 4.5 mm incision. By hydro, we take out the nucleus out of the bag into the anterior chamber by the help of 2 Simsky hook. You can see the nucleus quite hard, and without any hesitation, without any problem, we can take it out without any increasing our BP. Once the nucleus in the bag, the irrigative axis goes inside. Once we are taking it out, you start the irrigation and we can take out. You can see this is the hard nucleus we have taken out. So you have very good cornea, no chance of damage to endothelium. That's the surgery is same. I'm just running up. You can implant even the PMF lens because the patient was poor patient. We have done PMF lens and we have corrected astigmatism also. So toric effect in SICS can be achieved, not in the Phaco. And we can remove the hardest lens without any problem. This is the beauty of this SICS surgery. I'm showing again another case. This is another case.
1 minute left.
This is another case I want to show. So this incision is only 4 mm, but horizontally straight incision, and we are making vertical extension of 1 mm on both the sides. You see 1 mm already made on one side, and we are making another on the other side. So 4 mm straight incision, 1 mm vertical incision, and we can take out any type grade of nucleus very easily. It will cause postoperatively only 0.5 to 0.75 diopter astigmatism. See this surgery. This is a special cannula. You see this is a cannula. This is a cannula which has a bed here. Cannula has a bed over which the nucleus rests, and we can take out nucleus easily. This is cannula 20 gauge cannula, viscoelastic inside it. We keep pushing viscoelastic and take out the nucleus easily. You can see this is the hardest nucleus which can be taken out so easily by SICS. This is the black cataract, what we call it, grade 5, grade 6, whatever we call it. So we can implant the foldable lens, we can implant the non-foldable lens, all types of lenses in this. This is the beauty of SICS surgery. Thank you very much.
Thank you, Dr. Satanshu. It was worth waiting to see all your dramatic videos. Dr. Kamaljeet, would you want to comment on it? Sorry.
Yes, I would like to comment. The other speaker is not there.
No, he's not there.
He's not there. He's not lifting the phone. I tried calling him.
He has already run away. Phaco surgeon already ran away, seeing that SICS is
Actually,
important.
I am doing both the surgeries, SICS and phacoemulsification both. So I always feel that both are essential. And Dr. Mathur has covered the SICS. Phacoemulsification in hard cataracts many a time becomes slightly tricky. The corneal, these patients are old patients. Endothelial cell count is already less. And with better machines and expert phaco surgeons, they can do it without any problem. But most of the surgeons in our country are well versed with SICS, so they can easily do SICS, and the results are very good. I have compared both the things, the SICS and phacoemulsification. I found that it's much easier to finish the surgery with SICS and grade 5 cataracts. So these are my small comments on these topics. Thank you.
Most important is that in SICS you take less time in comparison to phaco in hard cataract, less energy, and there is no energy use. Number two, many surgeons in India are not able to have this high-end machines, not able to have this backup of the cornea surgeon or the retina surgeon. So my opinion, you may differ it because you phaco surgeon. I know every surgeon should be a compressive cataract surgeon. We should know all the types of surgery. We can use whatever we like in particular case.
Yes, yes. Thank you. I think we'll have to conclude. There have been excellent set of speakers. I do believe all of us who have sat through it, that's been a very vibrant webinar with lot of exchanges of ideas, lots of learning, and lot of skill sets of each individual came to light. It was really heartening for us. Our special thanks to our truly expert panel, the wonderful team of speakers. My thanks to my wonderful team of a very strong ARC team which I have. Special thanks to Kripal and his admin team of AIOS, Mr. Sunil, webinar admin, Mr. Sai, Manjula from Pneumotech for their guidance and support. My special thanks, our special thanks to Entold for constantly being there with us. My very, very, very special thanks to Dr. Srinivas Joshi for dealing with all anterior segment topics as if he was an anterior segment surgeon. I was amazed at the amount of knowledge this young boy has. And our heartfelt thanks to all the attendees who energize all of us to perform better and better each time. Thank you, one and all of you. Thank you.
Thank you very much, Chitra, for the wonderful opportunity.
Yeah, thank you. It was very nice.
Great webinar as usual.
Thank you. Yeah,
Thank
we
you.
should
Very vibrant.
have fewer topics and
All the debaters were very good. Hats off to all of them. We learned a lot.
We learned a lot.
We learned a lot.
Learned a lot, yeah.
Amurthy sir, thank you so much.
Srinivas, you were damn good.
Yeah, thank you,
Everybody, all the speakers, Dr. Amit is there.
Yeah.
Your mobile so well.
Thank you.
And Dr. Jasprit, Dr. Tennarson. Thanks a lot, Namrata, for your impromptu advices. Suchi Smita.
Thank you.
Neetam Samant, you are the hero always. Dr. Kamal